further in Tamil Nadu. Unnatural and premature deaths are always a tragedy. We need to do everything and anything to prevent such deaths. But at the same time, when such a death happens, the organs of the deceased person have to be utilized for giving a second lease of life for those suffering with organ failure. Organ failure, particularly that of kidney, liver, heart, and lungs, are progressively on the increasing trend. The reasons are twofold. Lifestyle diseases like diabetes and high BP and obesity on the one hand, and environmental changes like heat stress and pollution and chemicals exposure in life, on the other hand, are taking a heavy toll on the mankind. There is a huge gap between the demand for organs and the supply for organs. As one of the measures to sensitize and enhance our own knowledge on disease organ donation, this webinar is organized. It is very important and essential to update our knowledge on the science behind organ donation. Every step of diseased organ donation transplantation, it has challenges and it requires a lot of sensitivity and diligence. The topics for today's webinar have been chosen to cover the most important aspects of the program. And ladies and gentlemen, it is a great achievement of the government of Tamil Nadu that a sophisticated test treatment like organ transplantation has become accessible and available to the common man of Tamil Nadu. Organ transplants are happening in 13 government institutions, and another 27 government hospitals have been identified as non-transplant organ retrieval centers. And so 40 government hospitals are included in the program. This is the highest number in the entire country. I thank profusely our Honorable Minister for that. It is because of his initiative that has happened. I am sure with the guidance and encouragement of our Honorable Minister, we will take up this program to greater strides. Thank you, everyone.
அடுத்ததாக தமிழ்நாடு உறுப்பு மாற்று ஆணையத்தின் சார்பாக மாண்புமிகு அமைச்சர் அவர்களுக்கு பொன்னாடை போட்டி சிறப்பு செய்யப்படுகிறது. அடுத்ததாக சென்னை மருத்துவக் கல்லூரி முதல்வர் அவர்களை வாழ்த்துரை வழங்குமாறு அன்புடன் அழைக்கிறோம்.
Respected Honorable Health Minister, respected Health Secretary Sir, respected Director of Medical Education, the Director of Multispeciality Dr. Bhattacharjee, Member Secretary Professor NGK, today's speakers of webinar, and faculties who have joined in this webinar. First of all, I wanted to thank our Honorable Health Minister for appointing our Professor N.G. Gopalakrishnan as Member Secretary. I am very sure, sir, will take up this project and we will get back the #1 position to our state very soon. Sir, after taking over as Health Minister, this is the 3rd meeting I'm attending, and he was very keen in improving the performance of each and every hospital. As sir said, nearly 40 government hospitals have got the recognition and license for getting the organ retrieval. I just want to share how we are performing in Rajiv Gandhi Government General Hospital. We have a dedicated 2-bedded unit adjacent to the emergency department, headed by emergency medicine department Professor Dr. Gomadi, along with her team, Dr. Tanuj and Jayanti, is sincerely involving in managing these patients. Especially once the brainstem dysfunction is declared, they take over and diligently they follow the protocols. And after that, they counsel the patient attender. And almost in the year 2022, 16 brain dead patients were certified. And this year up to July, 12 bodies, actually brain dead patients were certified and organ retrieval has been done. And also, in government, Rajiv Gandhi Government General Hospital, 300 organ deceased donor kidney transplant have been taken place. And recently, The 4 liver transplant also have been taken place in the Rajiv Gandhi Government General Hospital. These are all possible because of our constant motivation by our Honorable Health Minister. And definitely, sir, we will assure you that we will get back the #1 position to our state very soon, sir, under your leadership. Thank you for this opportunity. Thank you, one and all.
அடுத்ததாக மருத்துவ கல்வி இயக்குனர் அவர்களை வாழ்த்துரை வழங்குமாறு அழைக்கிறோம்.
Good morning all. Respected Minister for Health and Family Welfare, Sir, Government of Tamil Nadu, and Dean Rajiv Gandhi General Hospital, MMC, Director, Collage Centenary Super Specialty Hospital, and the most important person now today, Dr. Gopal Krishnan, Sir, Member Secretary, Transplant. So I really appreciate, Sir, for organizing this webinar on this program. And basically, I'm from MMC. I know from 2008 that our post anesthesia care unit was established for this organ donation, especially the brain dead maintenance program was conducted from 2008 onwards. We were the part of that system, actually. I'm very happy to see that our pioneer hospitals always to be the #1, and also the sustainability should be maintained and the development should be there. And really appreciate this team of this organ donation team, especially the retrieval team, those who are supporting team, everybody is involved in this aspect, and appreciation to all. And I request the MMC RGGH team to coordinate with other hospitals so that the involvement and dedication of this can be dispersed to other hospitals also. So we'll be #1 in always position. Not only the #1 means, the main issue is we are able to give some life to so many people, sustainable life. That aspect, we have to do the work. So I really appreciate Dr. Gopal Krishnan for organizing the webinar as soon as he's taken over this Member Secretary of Transplant, and wish them a grand success of this program. And please request all the teams, especially the doctors of this program, plus the supporting team, all them wish them a grand success of continuous sustainable program. Thank you.
அடுத்ததாக மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நல்வாழ்வுத்துறை அமைச்சர் அவர்களை கருத்தரங்க சிறப்புரையாற்றுமாறு அன்புடன் அழைக்கிறோம்.
உறுப்பு மாற்று அறுவை சிகிச்சை தொடர்பான இணைய வழி கருத்தரங்கத்திற்கு வருகை தந்து வந்திருப்பவர்களை வரவேற்று சிறப்பித்து விட்டிருக்கிற உறுப்பினர் செயலர் பெருமதிப்பிற்குரிய மருத்துவர் கோபாலகிருஷ்ணன் அவர்களே, இங்கே எனக்கு முன்னால் உரை நிகழ்த்தி சிறப்பித்திருக்கிற பெருமதிப்பிற்குரிய மருத்துவ கல்வி இயக்ககத்தின் இயக்குனர் பெருமதிப்பிற்குரிய மருத்துவர் சாந்தி மலர் அவர்களே, உரை நிகழ்த்தி சிறப்பித்திருக்கிற ராஜீவ்காந்தி அரசு பொது மருத்துவமனையின் முதல்வர், மருத்துவக் கல்லூரியின் முதல்வர் பெருமதிப்பிற்குரிய மருத்துவர் தேரணிராஜன் அவர்களே, இந்த நிகழ்ச்சி இங்கே சிறப்புடன் அமைய காரணமாக இருந்து கொண்டிருக்கிற அன்பிற்கினிய கலைஞர் நூற்றாண்டு உயர் சிறப்பு மருத்துவமனையின் இயக்குனர் மதிப்பிற்குரிய மருத்துவர் திரு பார்த்தசாரதி அவர்களே, வருகை தந்திருக்கின்ற மருத்துவர் பெருமக்களே, இணைய வழியே இங்கே நம்மோடு இணைந்திருக்கிற பல்வேறு மாநிலங்களிலிருந்தும் வருகை தந்திருக்கின்ற மருத்துவர் பெருமக்களே, குறிப்பாக ஆந்திரா, கேரளா, பாண்டிச்சேரி, தெலுங்கானா, கர்நாடகா ஆகிய பல்வேறு மாநிலங்களிலிருந்து உறுப்பு தான திட்ட தலைவர்கள் இதில் பங்கேற்று சிறப்பித்திருக்கிறீர்கள். இது மட்டுமல்லாது தமிழ்நாட்டில் உள்ள அனைத்து அரசு மருத்துவக் கல்லூரி மருத்துவமனை தலைவர்களும், துறைகளை சார்ந்த சிறப்பு மருத்துவர்களும், உறுப்பு தான திட்டத்தின் கீழ் அமைந்திருக்கிற தனியார் மருத்துவமனைகளின் தலைவர்களும், மருத்துவர்களும் மற்றும் உறுப்பு தான ஒருங்கிணைப்பாளர்களும் இந்த கூட்டத்தில் பங்கேற்று சிறப்பித்துக் கொண்டிருக்கிறீர்கள். இந்த நிகழ்ச்சியை நான் தொடங்கி வைப்பதில் உண்மையிலேயே மகிழ்ச்சி அடைகிறேன். நம்முடைய மருத்துவர் தேரணிராஜன் அவர்கள் இங்கே பேசும்போது, இது நேரடியாகவே 2 கூட்டங்கள் ஏற்கனவே கல்லூரி முதல்வர்களுடனான கூட்டங்கள் 2 கூட்டங்கள் ஏற்கனவே நடைபெற்றிருக்கிறது. சென்னையில் ராஜீவ்காந்தி மருத்துவமனையில் ஒன்றும், கோவையில் ஒன்றும், இன்றைக்கு 3வது நிகழ்ச்சியாக இது நடைபெற்றுக் கொண்டிருக்கிறது. 2 ஆண்டுகளில் இந்த அரசு பொறுப்பேற்றதற்கு பிறகு 3 முறை கல்லூரி முதல்வர்களோடும் உறுப்பு தானம் பற்றிய அந்த விழிப்புணர்வுக்காகவும் உறுப்பு தானத்து பற்றிய செய்திகளை அனைவரும் தெரிந்து கொள்ளுகிற வகையிலேயும் அதனுடைய சிறப்பம்சங்கள் குறித்த ஒரு சிறப்பான வகையில் ஏற்கனவே 2 கூட்டங்கள் நடைபெற்று முடிந்திருக்கிறது. இது 3வதாக இந்த கூட்டம் நடைபெற்றுக் கொண்டிருக்கிறது. மருத்துவர் தேரணி ராஜன் சொன்னார், மருத்துவத்துறை வரலாற்றில் கல்லூரி முதல்வர்களுடன் இது மாதிரியான உறுப்பு தானத்தை பற்றி பேசிய கூட்டங்கள் என்பது இதுவரை நடத்தப்பட்டதே இல்லை. இந்த கடந்த 2 ஆண்டுகளில் தான் இது 3வது முறையாக இந்த கூட்டங்கள் நடைபெற்றுக் கொண்டிருக்கிறது என்கின்ற மகிழ்ச்சியான செய்தியினை சொன்னார். 2008ஆம் ஆண்டு முத்தமிழறிஞர் கலைஞர் அவர்கள் முதல்வராக இருந்தபோதுதான் உறுப்பு தானம் பற்றிய ஒரு பரவலான செய்தி உலகுக்கு தெரிய வந்தது. செங்கல்பட்டுக்கு அருகிலே இருக்கிற திருப்போரூரை சேர்ந்த ஹிதேந்திரன் என்கின்ற ஒரு மாணவன் இருசக்கர வாகனத்தில் விபத்தில் சிக்கி மரணமடைந்த நேரத்தில் அந்த மாணவனின் பெற்றோர் 2 பேரும் மருத்துவர்கள் உடனடியாக அந்த மாணவனின் உடல் உறுப்புகளை தானம் செய்ய முன்வந்து, இந்த உடல் உறுப்புகளின் மூலம் எங்களுடைய மகனை நாங்கள் திரும்பவும் பார்க்கிற அந்த மகனின் அந்த உறுப்புகள் செயலாக்கத்தின் மூலம் அவரை மீண்டும் நாங்கள் உயிர் பெற வைத்திருக்கிறோம் என்கின்ற வகையில் மகிழ்ச்சியோடு உறுப்பு தானங்களை தந்தார்கள். முத்தமிழறிஞர் கலைஞர் அவர்கள் அந்த மருத்துவர்களை அழைத்து பாராட்டியது மட்டுமல்ல, அவர்களுடைய சிறப்பு குறித்து பல்வேறு அறிக்கைகளையும் வெளியிட்டார்கள். தொடர்ச்சியாக தமிழகத்தின் இன்றைய முதல்வர், அன்றைக்கு துணை முதல்வராக இருந்தவர், இந்த உறுப்பு தானம் ஊக்கப்படுத்திய பெற்றோரை நேரடியாகவே அவர்களுடைய வீட்டுக்கு சென்று பாராட்டினார்கள். அப்பொழுது முத்தமிழறிஞர் கலைஞர் அவர்கள் செப்டம்பர் திங்கள் 5ஆம் தேதி தமிழகத்தில் மூளைச்சாவு உறுப்பினர் மாற்று திட்டம் என்கின்ற ஒரு திட்டம் அன்றைக்கு தொடங்கப்பட்டது. அந்த மூளைச்சாவு உறுப்பு மாற்று சிகிச்சை திட்டத்தை முத்தமிழறிஞர் கலைஞர் அவர்கள் 2008ஆம் ஆண்டு தொடங்கியதற்கு பிறகுதான் இந்தியா முழுவதிலும் இதற்கான விழிப்புணர்வு என்பது ஏற்பட தொடங்கியது. முத்தமிழறிஞர் கலைஞர் அவர்களால் தொடங்கப்பட்ட இந்த திட்டம் 2014 டிசம்பர் திங்கள் 12ஆம் தேதி ஒரு ஆணையமாக உருவெடுத்தது. தமிழ்நாடு உறுப்பு மாற்று ஆணையமாக அன்றைக்கு அது உருவாக்கப்பட்டது. இப்படி ஒரு ஆணையமாக உருவாகி இது மற்ற மாநிலங்களுக்கு ஒரு எடுத்துக்காட்டான வகையில் மிக சிறப்பாக செயல்பட்டு கொண்டிருக்கிறது. நம்முடைய கல்லூரி முதல்வரும் டிஎம்இயும் பேசும்போது சொன்னதை போல 2008ஆம் ஆண்டு முதல் இந்தியாவிலேயே தமிழ்நாடு தான் தொடர்ச்சியாக முதலிடத்தில் உறுப்பு மாற்று அறுவை சிகிச்சைகளை பொறுத்தவரை முதலிடத்தில் இருந்து வந்தது. ஆனாலும் கடந்த ஆண்டு தெலுங்கானா, மகாராஷ்டிரா போன்ற மாநிலங்கள் நம்மோடு போட்டி போட தொடங்கி இருக்கிறது என்கின்ற வகையில் அவைகளும் மிக சிறப்பாக செயலாற்றி கொண்டிருக்கிறது. எனவே போட்டி என்று வந்தால்தான் நமக்கும் கூட நல்லது. ஒட்டுமொத்தமாகவே போட்டி இல்லாமல் ஒரு 7-8 வருடம் நாம் தனியாளாக இருந்து முதலிடத்துக்கு வந்தது என்பது பெருமைக்குரிய விஷயம் அல்ல. இப்பொழுது மகாராஷ்டிரா, கேரளா அல்லது ஆந்திரா போன்ற மாநிலங்கள் போட்டி போட துவங்கி இருப்பதால் நிச்சயம் அந்த போட்டியில் நாம் நின்று நிலைத்து வென்று எப்பொழுதும் போல் இந்த உறுப்பு மாற்று அறுவை சிகிச்சையில் நாம் முதலிடத்தில் இருக்கிறோம் என்கின்ற நிலையை எட்ட வேண்டியது என்பது அவசியமான ஒன்று. எனவே காலி மைதானத்தில் கோல் போடுவதை விட மிகுந்த போட்டிக்குரிய மைதானத்தில் நாம் வெற்றி பெறுவதே இலக்கு என்கின்ற வகையில் இந்த போட்டியை நாம் எடுத்துக்கொள்ள வேண்டும். அதனால்தான் கடந்த 2 முறை நாம் இந்த கூட்டத்தை கூட்டியிருக்கிறோம். 3வதாகவும் இது இணைய வழியாக இந்த கூட்டம் நடத்தப்பட்டு கொண்டிருக்கிறது. நான் இந்த கூட்டத்திற்கு வருகிற போதே இன்று காலை இந்த கூட்டம் இருக்கிறது என்று தெரிந்தவுடன் நம்முடைய மாண்புமிகு தமிழ்நாட்டின் முதலமைச்சர் அவர்களிடத்தில் ஒரு கருத்தை கேட்டேன். மிக சிறப்பாக மூளைச்சாவு அடைந்தவர்களிடத்தில் உறுப்புகளை தானமாக பெறுவதும் அவர்களை சம்மதிக்க வைப்பது என்பது அந்த நேரத்தில் கடினமான ஒரு விஷயம். மூளைச்சாவு அடைந்தவர்கள் மிகுந்த கவலையோடு அவருடைய குடும்பத்தினர் இருப்பார்கள். அந்த உற்றார் உறவினரை பெறுவதை அவர்களை சம்மதிக்க வைப்பது என்பது சாதாரணமான காரியம் அல்ல. 1. 2வது, அப்படி பெறப்பட்ட உறுப்புகளை தகுதி உள்ளவர்களுக்கு தருவதிலும் இருக்கிற சிக்கல். யார் யார் எங்கே எந்தெந்த உறுப்புகளுக்காக காத்திருக்கிறார்கள் என்கின்ற பட்டியலை பெற்று அதையும் முறையாக முன்னுரிமை அடிப்படையில் அவர்களுக்கும் அதை தருவது என்பது ஒரு பெரிய அளவிலான அட்மினிஸ்ட்ரேட்டிவ் சிக்கல். அதையும் கடந்து இது அந்த இரத்த மாதிரிகள் அதாவது சரியானதற்கு பிறகு அவர்களுக்கு தரப்பட்ட அந்த உறுப்புகள் தொடர்ந்து சரியாக இயங்குகிறதா என்பதை கண்காணிப்பது என்பதும் தொடர்பணி. இப்படி பல்வேறு பணிகளையும் நாம் தொடர்ச்சியாக இதில் செய்து கொண்டிருந்தால்தான் இதில் நாம் வெற்றி பெற்றிருக்கிறோம் என்ற அர்த்தம். எனவே பெரிய அளவிலான கஷ்டமும் கூட இதில் இருக்கிறது. நம்முடைய மெம்பர் செக்ரட்டரி இங்கே பேசும்போது சொன்னார், இதற்கு முன்னால் ஒரு 13 மருத்துவமனைகளில் மட்டுமே உறுப்பு தானம் பெறுவதும் உறுப்பு மாற்று அறுவை சிகிச்சைகளும் நடைபெற்றுக் கொண்டிருந்தது. இன்றைக்கு கடந்த முறை நாம் கோவையிலே நடத்திய கூட்டத்தில் பல்வேறு கல்லூரி முதல்வர்கள், இங்கே நீங்கள் இணைய வழியாக இணைந்திருக்கிறீர்களே, இந்த முதல்வர்கள் கூட நிறைய பேர் எங்கள் கல்லூரிக்கு இந்த உறுப்பு தானம் பெறுவதற்குரிய உரிமங்கள் வழங்கப்பட வேண்டும் என்கின்ற கோரிக்கையை வைத்தீர்கள். அப்பொழுது அந்த கூட்டத்திற்கு டிஎம்எஸும் அழைக்கப்பட்டிருந்தார். இப்பொழுது டிஎம்இ இங்கே வந்திருப்பதை போல டிஎம்எஸ் அந்த கூட்டத்திற்கு வந்திருந்தார். உரிமத்தை யார் வழங்க வேண்டும் என்ற போது டிஎம்எஸ் தான் உரிமம் வழங்க வேண்டும் என்றார்கள். அவருக்கு அந்த இடத்திலேயே நாம் சொன்னது, உடனடியாக எத்தனை மருத்துவமனைகள், அரசு மருத்துவமனைகள் உறுப்பு தானத்திற்கான உரிமத்திற்கு விண்ணப்பித்திருக்கிறார்களோ அதையெல்லாம் உடனடியாக பரிசீலித்து அவர்களுக்கு உரிமங்கள் வழங்கிட வேண்டும் என்று சொன்னோம். சொன்ன 1 மாத காலத்திற்குள் தமிழ்நாட்டில் 27 புதிய உறுப்பு தானத்திற்கான அந்த உரிமங்கள் உடனடியாக வழங்கப்பட்டிருக்கிறது. அதைத்தான் நம்முடைய உறுப்பினர் செயலர் பேசும்போது, தமிழ்நாட்டில் இப்பொழுது 40 மருத்துவமனைகளில் இந்த உறுப்பு மாற்று அறுவை சிகிச்சைக்கான வாய்ப்புகள் இருக்கிறது என்றார். அதில் இன்னும் ஒரு கூடுதல் சிறப்பு, இந்தியாவில் இருக்கிற 36 மாநிலங்களில் தமிழ்நாட்டில்தான் அதிகமாக உறுப்பு மாற்று அறுவை சிகிச்சை செய்வதற்குரிய மருத்துவமனைகள் தமிழ்நாட்டில் இருக்கிறது என்கின்ற வகையில் அவர் இங்கே பெருமைப்பட்டுக் கொண்டார். ஆக 40 மருத்துவமனைகள் இன்றைக்கு இருப்பதற்கு காரணம் 27 மருத்துவமனைகளுக்கு புதிதாக உறுப்புகளை பெறுவதற்குரிய அந்த உரிமங்களை கடந்த 6-7 மாதங்களுக்கு முன்னால் தந்ததுதான். என்றாலும் கூட நமக்கு இருக்கிற ஒரு பெரிய சவால் இப்பொழுது, இதை மற்ற மாநிலங்களும் எடுத்து சிறப்பாக செயல்பட்டு வருகிற காரணத்தினால் அவர்களோடு போட்டி போட்டு அடுத்த ஆண்டு வருகிற போது தொடர்ந்து எப்படி நாம் ஒரு 10 ஆண்டு காலமாக முதலிடத்தில் இருந்தோமோ அதே இடத்திற்கு மீண்டும் வருவதற்கும் அந்த இடத்தை தக்க வைப்பதற்கும் நாம் இந்த கூட்டத்தின் வாயிலாக உறுதி ஏற்றுக்கொள்ள வேண்டும். அந்த வகையில் தான் இன்றைக்கு மாண்புமிகு தமிழ்நாட்டின் முதலமைச்சர் அவர்களிடத்தில் இதில் இருக்கிற இடர்பாடுகள், இதில் இருக்கிற சிக்கல்கள், இந்த கடினமான உழைப்பு, இவற்றையெல்லாம் மனதில் கொண்டு எந்த கல்லூரியில் இந்த ஆண்டு அதிகமான உறுப்பு மாற்று அறுவை சிகிச்சைகள் செய்திருக்கிறார்களோ, எந்த கல்லூரியில் மூளைச்சாவு அடைந்தவர்களிடத்தில் அதிக எண்ணிக்கையில் உறுப்புகளை பெற்றிருக்கிறார்களோ, எந்த கல்லூரியில் அவர்கள் செய்த சிகிச்சைகள் 100% வெற்றி பெற்றிருக்கிறதோ, இவற்றிலெல்லாம் கணக்கில் எடுத்து ஒரு குழுவை நியமித்து அந்த குழு இந்த மருத்துவமனைகளை பரிசீலனை செய்து இவற்றிலெல்லாம் நான் சொன்ன இந்த காரணிகளிலெல்லாம் யார் முதலிடத்தில் வருகிறார்களோ அவர்களுக்கு ஒவ்வொரு ஆண்டும் நம்முடைய மாண்புமிகு தமிழ்நாட்டின் முதலமைச்சர் அவர்கள் சுதந்திர தின விழாவில் இன்றைக்கு பல்வேறு தரப்பினருக்கு விருதுகளை தருகிறார்கள். கல்பனா சாவ்லா விருது போன்ற பல்வேறு விருதுகள் இன்றைக்கு சுதந்திர நாளில் மாண்புமிகு முதலமைச்சர் அவர்களால் வழங்கப்படுகிறது. அப்படி வழங்கப்படுகிற அந்த நிகழ்வில் இந்த உறுப்பு தான சிகிச்சையில், உறுப்பு மாற்று அறுவை சிகிச்சையில், உறுப்பு மாற்று விழிப்புணர்வு நிகழ்ச்சியில் கூடுதல் கவனம் செலுத்துகிற அந்த கல்லூரியின் முதல்வருக்கும் அங்கே சுதந்திர நாள் விழாவில் மாண்புமிகு முதலமைச்சர் அவர்களின் மூலம் விருது வழங்கிட வேண்டும் என்கின்ற கோரிக்கையை இன்றைக்கு நாம் மாண்புமிகு தமிழ்நாட்டின் முதலமைச்சர் அவர்களிடத்தில் தெரிவித்தோம். மாண்புமிகு தமிழ்நாட்டின் முதலமைச்சர் அவர்கள் உடனடியாக ஒப்புக்கொண்டு அறிவித்து விடுங்கள், அடுத்த ஆண்டு இந்த ஆகஸ்ட் முடியாது நிச்சயம். ஏனென்றால் நான் சொன்ன இந்த காரணிகள் எல்லாம் இறந்த நன்கொடையாளரின் பராமரிப்பு, மூளை இறப்பு சான்றிதழ் செயல்முறைகள், இறந்த நன்கொடையாளர் உறுப்பு மீட்பு கண்ணோட்டம், இப்படி பல விஷயங்களை ஆய்வு செய்ய வேண்டியிருக்கும். இந்த 1 மாத காலத்தில், 1 மாத கூட இல்லை, இன்னொரு 15-20 நாட்கள் தான் இருக்கிறது. எனவே இந்த குறுகிய கால இடைவெளியில் இந்த விருதுக்குரியவரை தேர்வு செய்வது என்பது இயலாத காரியம். எனவே அடுத்த ஆண்டு ஆகஸ்ட் திங்கள் 15ஆம் தேதி நம் தமிழ்நாட்டில் இருக்கிற அரசு மருத்துவக் கல்லூரி மருத்துவமனைகளில் ஏதாவது ஒன்றுக்கு சிறப்பாக செயல்படுகிற முதல்வருக்கு நம்முடைய மாண்புமிகு தமிழ்நாட்டின் முதலமைச்சர்களின் மூலம் விருது வழங்கப்படுகிற அந்த நிகழ்வு என்பது நடைபெறவிருக்கிறது என்பதை தற்போது பத்திரிகையாளரிடத்திலும் சொல்லியிருக்கிறேன். உங்களிடத்திலும் இப்பொழுது அதை சொல்வதை நான் பெருமையாக கருதுகிறேன். அதேபோல் இன்று இன்னொரு பிரச்சனைக்கும் தீர்வு காணப்பட்டிருக்கிறது. தமிழ்நாட்டை பொறுத்தவரை இந்த கொரோனா பேரிடர் காலத்தில் பணியாற்றிய மருத்துவர்களுக்கும் மருத்துவம் சார்ந்த களப்பணியாளர்களுக்கும் முன்னுரிமை தரப்பட வேண்டும் என்கின்ற கோரிக்கை தொடர்ந்து விடுக்கப்பட்டு வந்தது. அந்த வகையில் நம்முடைய மாண்புமிகு தமிழ்நாட்டின் முதலமைச்சருடைய வழிகாட்டுதலின்படி மாவட்டந்தோறும் எடுக்கப்பட்ட பணியிடங்களை பொறுத்தவரை டிஸ்ட்ரிக்ட் ஹெல்த் சொசைட்டி என்று சொல்லப்படுகிற அந்த பணியிடங்களில் தற்போது கூட ஒரு 500 நகர்ப்புற நலவாழ்வு மையங்களை திறந்திருக்கிறோம். அதற்கு தேவையான மருத்துவர்கள், மருந்தாளுநர்கள், சுகாதார ஆய்வாளர்கள், இப்படி செவிலியர்கள் போன்ற பல்வேறு பணியிடங்களுக்கு மெரிட் மார்க்ஸ் என்று அவர்களுக்கான மதிப்பெண்களை கொடுத்து ஏறத்தாழ கொரோனா பேரிடர் காலத்தில் பணியாற்றிய ஒரு 90% மேலான மருத்துவர்கள் மற்றும் மருத்துவம் சார்ந்த களப்பணியாளர்கள் டிஸ்ட்ரிக்ட் ஹெல்த் சொசைட்டியின் மூலம் பணியில் அமர்த்தப்பட்டிருக்கிறார்கள். இது இந்தியாவிலேயே தமிழ்நாட்டில் மட்டுமே ஒரு மனிதாபிமானத்தோடு செய்யப்பட்டிருக்கிற ஒரு காரியம். இருந்தாலும் மருத்துவர்களுடைய இன்னொரு கோரிக்கை, இந்த எம்ஆர்பியின் மூலம் நடைபெறுகிற தேர்வுகள், மெடிக்கல் சர்வீசஸ் ரெக்ரூட்மெண்ட் போர்டு என்று சொல்லப்படுகிற இந்த எம்ஆர்பியின் மூலம் நடைபெறுகிற தேர்வுகளில் தற்போது ஒரு 3 பணிகளுக்கான தேர்வுகள் நடைபெற்றுக் கொண்டிருக்கிறது. 1021 மருத்துவர்கள், 983 மருந்தாளுநர்கள், 1066 சுகாதார ஆய்வாளர்கள், இவர்களுக்கான தேர்வுகள் நடைபெற்றுக் கொண்டிருக்கிறது. 1021 மருத்துவர்களுக்கு 25,000 பேர் தேர்வு எழுதியிருக்கிறார்கள். அதேபோல் 983 மருந்தாளுநர்களுக்கு 43,000 பேர் தேர்வு எழுதியிருக்கிறார்கள். 1066 சுகாதார ஆய்வாளர்களுக்கு ஏறத்தாழ 60,000த்திற்கும் மேற்பட்டவர்கள் விண்ணப்பித்திருக்கிறார்கள். இவர்களை தேர்ந்தெடுக்கும் போது பெரிய அளவில் அவருடைய திறமை, கல்வி தகுதி போன்ற பல்வேறு விஷயங்களை ஆய்வு செய்ய வேண்டியிருக்கிறது எம்ஆர்பி நிர்வாகத்தால். எனவே நம்முடைய மருத்துவர்களுடைய கோரிக்கையும் செவிலியர்கள், மருந்தாளுநர்கள் போன்ற அனைத்து தரப்பினருடைய கோரிக்கையும் எம்ஆர்பி மூலம் எடுக்கப்படும் போதுதான் எங்களுக்கு எதிர்காலத்தில் பணி நிரந்தரம் எல்லாம் கிடைக்கும். எனவே எங்களுக்கு இந்த மெரிட் மார்க்ஸ் என்பது இதிலும் கூட தரப்பட வேண்டும் என்கின்ற கோரிக்கை வைத்திருந்தார்கள். அதையும் இன்று காலை மாண்புமிகு தமிழ்நாட்டின் முதலமைச்சர்களிடத்தில் எடுத்துச் சொல்லி மருத்துவர்களுக்கும் செவிலியர்களுக்கும் மருந்தாளுநர்களுக்கும் தற்போது நடைபெறவிருக்கிற அந்த தேர்வில் 5 மெரிட் மார்க்ஸ் தரப்படவிருக்கிறது. 2 ஆண்டுகள் யாரெல்லாம் கொரோனா பேரிடர் காலத்தில் 2 ஆண்டுக்கும் குறையாமல் பணியாற்றினார்களோ அவர்களுக்கெல்லாம் இந்த மதிப்பெண்கள் தரப்படவிருக்கிறது என்கின்ற மகிழ்ச்சியான செய்தியினையும் இந்த நேரத்தில் தெரிவித்துக் கொள்வதில் பெருமை அடைகிறோம். இந்த துறையை பொறுத்தவரை மருத்துவர்களின் இடமாற்றங்களாக இருந்தாலும், பணியிடங்களை நிரப்புகிற பணிகளாக இருந்தாலும், பதவி உயர்வாக இருந்தாலும் எல்லாமே டிரான்ஸ்பரண்டாக நடைபெற்றுக் கொண்டிருக்கிறது. எனவே இந்த டிரான்ஸ்பிளான்ட் நிகழ்ச்சியில் டிரான்ஸ்பரண்டான இந்த நிர்வாகத்திற்கு நீங்கள் கூடுதலான ஒரு ஒத்துழைப்பை தர வேண்டும் என்கின்ற வகையில் இத்துறையை முதன்மையான இடத்திற்கு கொண்டு வர வேண்டும் என்கின்ற என்னுடைய கோரிக்கையை வலியுறுத்தி வாய்ப்புக்கு நன்றி கூறி விடைபெறுகிறேன். நன்றி, வணக்கம்.
மாண்புமிகு அமைச்சர் அவர்களுக்கு ஒரு அன்பான வேண்டுகோள். ராஜீவ்காந்தி அரசு பொது மருத்துவமனையில் மாற்று உறுப்பு அறுவை சிகிச்சைகளை, அந்த பணியினை திறம்பட செய்து வரும் மருத்துவர்களை கௌரவிக்குமாறு பணிவுடன் கேட்டுக்கொள்கிறேன். ப்ரொஃபசர் ராகவேந்தர், நியூரோ சர்ஜரி. Professor Lakshmi Narasimhan. I thank Professor Lakshmi Narasimhan. He retired yesterday as director. Still, he wants to deliver a talk today. Professor Edil Sundar, Professor of Urology. Professor Mariappan, Professor Gomati Karmegam. She is in charge of emergency medicine and she is taking care of deceased donors. Dr. Tanuj, Assistant Professor Nephrology, and Dr. Jayanti, Assistant Professor Anesthesia. They are the two important persons who maintain the deceased donors.
Check, hello, testing, hello, hello, check, hello, hello, testing.
Hey,
சிவா சிவா ஆ ஓகேவா ஆமாம்
I welcome you all once again. We'll start the academic session of today. I invite Professor Lakshmi Narasimhan, Director, Institute of Neurology, Madras Medical College, to deliver the first talk, the concept of brain death. What is brain death all about? He will explain that.
Good morning, everybody. At the outset, I thank the Almighty. Secondly, I thank the Tamil Nadu Health Services. They enjoyed for 33 years. 33 years of, I would say, golden period of my life. I enjoyed retired superannuation yesterday. A very graceful function organized by Professor Raghavendra and Professor Balasubramaniam. I'm not out of the emotional and this is my first post-retirement day. Some Professor Gopal Krishnan sir has gave a pleasant surprise by asking all of us to be honored by the minister. I thank you for his noble gesture. So, next slide. Next slide, please. And second disclaimer is, my apologies to Professor Raghavendra is going to talk on, there is bound to be some overlap between me and him. I apologize for that. Next slide. Thank you. So I'm going to talk on introduction, what are the historical aspects and some concepts in brain death and Indian perspectives and few case vignettes and take-home messages. So brain death implies a permanent absence of cerebral and brainstem functions. In the modern era, the determination of brain death has gathered much significance in the context of organ transplantation. Currently, advancement in critical care buys time to support the brain dead patients for the organ transplantation. If you really look at the curve, as the criteria of yesteryears for brain death will run into pages. As the science of transplantation grew more and more, the criteria for the brain death started shrinking and is far more assuming simpler shape as the need for the organs becoming more and more. You could see exactly the curves are in opposite directions. So what is brain death? Brain stem death or whole brain death. Now, the preferred criteria presently is a brain death or the brain death by neurological criteria. The DNC is a present word. You either write BDC bar DNC is what is the term now globally being. So the concepts, there are three things. One is the whole brain death. Brain death is equivalent to catastrophic injury to all the major structures in the brain. Cortex, diencephalon, the brain stem, cerebellum and all. But does not traditionally require the loss of neuroendocrine function. The pituitary, the portal hypophyseal pituitary, the lot of papers and a series of papers where the neuroendocrine portion of the brain still is functioning even after brain death. Thanks to that, the viability of the organs are maintained. So you know that most of them, the levothyroxine is being given for preservation of organs. The cortisol is being given. All these things, you should understand that we are just supplementing, but the neuroendocrine axis is still viable in spite of brain death. This is a point which I learned yesterday. Destruction of the brainstem is alone equivalent to human death is brainstem. See, in fact, you can't die twice. See, you certify somebody has brain death at such and such 21st See, for example, 1st August, you are certifying that so-and-so is brain dead. The family refuses or they don't want an organ donation. They wanted to continue life support. If they want to continue life support, they insist on continuing life support. And death happens 5 days later. What will you certify in the death? Which time? You can't die twice. You'll certify the brain death time or you'll certify I just see this was a question. Sometimes there's one more interesting concept evolved. There's something called chronic brain death. This is absolutely new to me. Somebody has declared brain dead. How long do you think they can survive? There is a very famous case series by John Valkes, where post brain death, the girl has survived for 4 years. She attained puberty in the 4 years. She continued to live for 4 years. So these are all anecdotal things. But they and that group starts promoting there's a condition called chronic brain death also. I'm not just here to confuse this. Few concepts which are evolving. We really do not know how long. There is no time frame that how long they will remain. There are papers to say, is it too early? There are papers which say that no, nothing is too early. We should, in fact, you have to advance it even further. I'll just throw you certain controversies in this area and the higher brain function, like bilateral hemispheres and all. These are the 3 major things. So declaration of brain death or death by neurologic criteria is an important and separate medical diagnosis that should be made independent of the need for organ transplant. Judaism does not accept the concept of brain death. Most of the other religions have accepted it. And there are premature burials in fear of incorrect death determination in 1854. Before 1950s, the concept of death is cessation of cardiorespiratory function followed by cessation of brain function. But when the CPR and the positive pressure ventilation came, then they realized that when you restore the circulation, the patient was functional. So the question of this, the concept of death cessation by cardiopulmonary, this thing was questioned. The death definition has to be revised. Until 1959, a very famous group, French group, Molleret and Golan, lead coma dépassé, where they found apneic patients, comatose, without brainstem reflexes, with flat silent electrocerebros silence. But they were pulse BP, everything was normal. They were producing urine, all these things. So that is a fairly a big group around. That's the first time where the concept of brain death they introduced. The Harvard Medical Committee in 1968 established clear criteria, and the timelines were AN and update of AN criteria they were kept on revising. So essentially, neuronal cell damage, tissue edema, increased intracranial pressure, reduced cerebral perfusion, anoxic. This is the vicious cycle of the pathway of brain death. The brain death can be due to extracranial injuries or intracranial injuries. Extracranial injuries like cardiopulmonary arrest, prolonged hypoxia, neuronal damage. Then that goes to cell membrane rupture, osmoregulation, cerebral edema, increased P and neuronal injury, or intracranial injury, neuronal damage, and again the same cycle ultimately result in neuronal damage. So, American Academy of Neurology guidelines says clinical evaluation establish irreversible proximate cause of coma, achieve normal core temperature, achieve normal systolic pressure, perform one neurological examination. I'll come back to this one neurological examination. Clinical evaluation, the following must be assessed: coma, absence of brainstem reflexes and apnea. 2 clinical evaluations done 6 hours apart is a requirement in India. Ancillary tests ordered only if the clinical examination cannot be performed. Documentation, time of death is documented, checklist out, signed, and dated. So this is the apnea test, which I don't want to get into it because my colleague is going to talk. Irreversible coma, known cause, absence of confounding factors, absence of motor response, apnea test, no spontaneous breathing, brain death. Apnea test, presence of spontaneous breathing, repeat apnea after an interval, no spontaneous breathing, again brain death. Apnea test aborted due to some procedure, go in for an ancillary test, confirms brain death, no, repeated after an interval. So this is the basic algorithm which he will be talking. Indian perspective, India follows the UK concept, and 1994 Act was passed in the Indian Parliament based on the transplantation of human organs. Despite this, brainstem is not promptly declared in India due to lack of awareness, for which my close friend Professor NGK will take all the steps so that it spreads across the country. Team of 4, medical administrator in charge of the hospital, authorized specialist, authorized neurologist, neurosurgeon, and medical officer in charge of it. Can life support be disconnected with the relatives' refused organ donation? They say refuse organ donation. Would you like to continue life support, or what is your views on this, madam? Would you like to discontinue? What is the legality of this? Discontinue the life support or continue the life support? They don't want organ donation, but they want aggressive treatment. Is there any standard operation protocol? The Kerala has given a SOP, which says the ventilatory support of a patient can be removed. I'm sorry. What happened? Slideshow. The ventilatory support of a patient can be removed if the brain death is confirmed after test without waiting for the consent from the relatives. Medical practitioners should have a conversation with the patient's skin regarding the medical status. Apnea test should be performed. Should be the last brainstem reflexes test to be performed. To declare a brain dead, a panel of doctors must perform the prescribed test twice in the minimum interval of 6 hours. If the criteria of brain death are met, the panel must declare the patient dead. All treatments, including cardiorespiratory support, must be discontinued. This is the only, I don't know what is the SOP in Tamil Nadu. I really don't know, but this is the first SOP issued by the Kerala. Says, okay, and I think, yeah, I think it's slowly the other states will also, for want of, so that would save quite a lot of health resources. So that's what I told. If the relatives request more time to decide about the organ donation during which the cardiopulmonary function, if the disease ceases, which time to record one. Again, abroad, the rules are very clear. The time of brain death is a time of death. But I don't know what we do here, madam. Second apnea. Okay, fine. Yeah. So the time of death is recorded as the time when the final test to fulfill the criteria for the brain term was satisfied. That is the time of death. So you can't die twice. You can die twice only in movies. So the confounding factors, drugs, electrolyte imbalance, spinal movements, and hypothermia. Just a couple of case vignettes I will explain. Presented with 41-year-old presented with hypoxia, 1 week cough, pleuritic chest pain, ECG S1 Q3 T3 pattern, CT angio was done, CT angio, main pulmonary artery occlusion, IV thrombolysis. During the infusion, he was started cardiac arrest, CPR was given, revived after 10 minutes. This is the ECG. You can see the S1 Q3 T3 pattern, and the main pulmonary artery. You can see the thrombus there. And examination, comatose, not responding, bilateral dilated, not reacting to light, the Dalsey movement impaired, corneal conjunctiva absent, gag reflex absent. Motor examination demonstrated triple flexion of the lower extremities, upper extremities, noxious stimulation of the right arm, resulted in ipsilateral flexion of the elbow, supinated arm, bringing forearm to the rest. What next? So you should understand that there are previously no movements, death is equivalent to no movements. I just want to tell it's not that way. There are all these kinds of all such kinds of movements can happen. The Lazarus sign, the undulation, undulated toe flexion sign, and all these things. These things, produce suspicion in the patients. Why I want to tell you, you should know how to explain, because some moments when after the brain death and we are planning to do an organ harvesting, at that time, some small movements which produce doubt in the mind, all the cinematic explanations also add fuel to their suspicion. Most of them are paranoid. And I should want you to understand these things can happen moments, and this is the Lazarus sign. Just watch this kind of movement. See, this is, you might have seen in a lot of somewhere, most of the times when they take the patients to the burial ground, when they put fire, these kind of moments happen and people are frightened and come back. All these things you might have seen in village stories. This is nothing but the Lazarus sign, which is the flexion movements. And so illustration of this famous thing, the Saint Cosmos and the Saint Damian, the two famous Arabian doctors, you can see that they are decapitated, but they are able to maintain the erect posture even after decapitation. Became skilled doctors, arrested, tortured, beheaded, but the postural tone was able to be maintained by this. So, sir, move on. Next slide. So the pathophysiology of this is hypoxic stimulation of neurons in the cervical spinal cord. Movements may be mechanically induced. Neural networks in the spinal cord acts as central pattern generators, and disinhibition of the vestibulospinal and the reticulospinal tracts. Next slide, please. So supranuclear pathway to the central spinal generators, vestibulospinal and the reticulospinal was inhibited. Next slide. Next slide. So you should understand that the movements are possible. The case we need 21-year-old male present with the history of RTA following the patient is unconscious, pupils dilated and fixed, absent brainstem reflex, CT brain, multiple hemorrhagic spots suggestive of diffuse axonal injury, CT suggestive of multiple rib fracture, ICD placed, apnea test could not be done due to lung injury. And what do you do next? So assess the blood flow. The ancillary tests come into play. DSA, CT angioperfusion, or assess electrical activity, electrocerebral silence by EEG, evoke potentials, and EEG protocol. This is the protocol, and what you look for is an electrocerebral inactivity, ECI, even with the intense somatosensory in the audiovisual, the flat and evoke potentials, absence of N20 and bilateral absence of N19, P22, absence of waves 3 to 5 in the brainstem auditory evoke potential, MRI brain, absent of intravascular flow, the diffuse cortical high signal intensity, bilateral transcerebral vein sign, bilateral, you can see this is you can see the bilateral cortical vein sign, and DSA, gold standard, no flow above terminal ICA, 100% sensitivity and specificity. In the radionuclide HMPAO scan, hot nose sign or empty light bulb sign, you can see empty skull sign and the empty bulb sign. So, and in TCD, systolic spikes with the reversal of diastolic flow, and lost nail in the coffin. The Varela et al. Neurology 2021, 266 patients cohort. Dual brain death examination was a single brain death. DBD average of 21 hours. If you do a dual blind death certification, like 2 tests, average time taken is 21 hours to decide. More organs were harvested in single BD cohort. Claims that DBD is medically and ethically unjustified. And after this, the US has adopted single test period. That's what, and given that wasting time is wasting valuable organs, because the survival of the organs also become viability post-transplant, everything becomes a question. This is one of the landmark paper which has done away with the second testing. So last nail in the coffin, take-home messages, brain death by neurological criteria determination is a nuanced process that must be performed thoughtfully and carefully to prevent false positive declarations of death. Electrolyte abnormalities, CNS depressants, hypothermia are important confounding factors. Spinal movements may occur, as I showed you. Adequate counseling has to be offered, and when the apnea test is aborted due to any reason, then that is the time only when you take the help of the ancillary tests. And thank you for your attention.
Thanks very much, Professor Lakshmi Narasimhan. Actually, it was an enthralling lecture. Thank you so much for accepting our invitation and delivering a nice talk. Of all the points which he said, the final point was the real punch. The time is gold over there. It's time is tissue here. Like every step of the disease donor transplantation program, time. Even a delay of 1 minute makes a difference, because it's very difficult to maintain the viability and vitality of the organs in a brain dead person. If there is so much delay in every step, ultimately what happens is that the organs may be apparently viable, but once they get transplanted into the recipients may not do well if there has been a great delay in this. Also, when the procedure is delayed, there is a vulnerability for invasion of infections. Maintenance of the diseased donor, invariably 6 to 7 will be the tube count. So every hour of delay makes huge difference. If there is sepsis, infection in the diseased donor, that will have a serious negative impact on the recipients. With this, thank you so much. May I call upon the second speaker, Professor Gomati Karmegam. She is in charge of emergency medicine, professor in emergency medicine, also in charge of the dedicated unit which is established by our dean for maintenance of deceased donors.
So, good afternoon, everybody. Thank you very much, Professor N. Gopalakrishnan sir, for this awesome opportunity. And I would also like to thank our dean at Madras Medical College for giving myself and my team this a very unique opportunity to present among this August meeting. So I will be dealing mainly about maintenance of diseased donors and the general considerations associated with it. My teammates will be speaking about the hemodynamics and, of course, the ventilatory management. Next. So, as we all know, at any given day at Rajiv Gandhi Government General Hospital in the emergency department, we will get on an average of 5 patients who are involved in road traffic accidents and head injury. So that will put the statistics, yearly statistics, at around 1,500 to 1,800 per year. But over a span of 20 months from December 2021, out of those 1,800, the number of brainstem dysfunction patients declared were 125, and out of those, only 30 were converted as potential organ donors. So the purpose of this slide is to tell you that a great deal of wiseness and prudence is needed while we are converting a brainstem dysfunction patient into a potential organ donor. Not everybody can be declared, and not everybody turns out to be a potential organ donor. Next. Next. Right. Okay, I'll use this. So we all know with improving healthcare, especially in cardiology, nephro, and hepatology, the lifespan of patients suffering with congestive cardiac failure or decompensated liver disease or CKD, their lifespan has been increasing, and thereby the demand for organ transplants is also increased. We also know that there is a considerable morbidity and mortality associated with live donor transplants. We have to take care of both the donor and the recipients, isn't it, in live donor? So obviously, diseased donors are a very good alternative. But the brainstem dysfunction patients require aggressive and intensive monitoring and optimization from the declaration of brain death to organ retrieval. Now, this is very, very hard work. So our words matter. So what previously we were calling as cadaver, we call as diseased donor, and now it's called brainstem death. And we don't call it organ harvesting anymore. We call it organ procurement. Right. As Lakshmi Narasimhan sir had said, what are the criteria for brainstem death? We all know it's irreversible coma, absence of brainstem reflexes, and no respiration. And we need to rule out poisoning, alcohol intoxication, drug overdose, hypothermia, hypoglycemia, coma, chronic vegetative states. We need to rule out all that. But there is a line saying that there are no universally agreed upon established levels of electrolytes, creatinine, glucose, or hepatic enzymes, meaning there is no fixed protocol through the entire world which agrees on all of this. Next. So the pathophysiology, just running into a quick pathophysiology, being an anesthesiologist, you need to be proactive and you need to know the pathophysiology to treat it before it happens, or at least you should know what to expect. So along with brainstem death, we all know that the hypothalamic pituitary and adrenocortical axis goes haywire. It's completely disrupted now. And with the ischemia that ensues over the pontine and the medulla oblongata, we get the Cushing reflex, wherein you will have bradycardia and hypertension. And as the hypoxia descends downwards into the lower medulla oblongata and your thoracic sympathetic chain, you're going to get your catecholamine storm. And when it reaches your thoracic sympathetic chain, you're going to have severe hypotension. So what starts with bradycardia and hypertension is going to progress onto tachycardia and hypertension, and then you're going to get profound hypotension. How does it hit the heart? The catecholamine surge is going to deplete your ATP in the myocytes, and the hypotension can lead on to vasodilatation, shock, and severe myocardial suppression. And the lungs bear the maximum brunt because during any RTA, there is going to be a delay in intubating the patient. Most of these patients aspirate. So we find only 10 to 20% of lungs are eligible for harvesting. And because of the catecholamine storm, we have profound neurogenic pulmonary edema, and there is a exorbitant release of pro-inflammatory mediators which cause lung injury. Coming to the endocrinology part, the posterior pituitary is hit the most and the anterior pituitary is spared, thankfully. But the posterior pituitary is associated with polyuria, polydipsia, and hypernatremia, which has to be tackled. The patient may have sick euthyroid syndrome and hyperglycemia because of the decreased insulin secretion and increased insulin resistance. Kidneys there will be a lot of infiltrating T lymphocytes and macrophages. And that is the reason why the kidneys which are taken from a deceased donor have acute tubular necrosis for nearly 2 weeks, and you have to help them out with dialysis. And of course, there is a lot of release of thromboplastin, which leads on to coagulopathy and leukocytosis. Now, in the past 2 slides, I think you must have a fair enough idea of what and all problems you are going to face and what you need to be prepared for. So when the apnea testing actually happens, you need to have all of this under your control. Otherwise, apnea testing does not happen. Now, the neurosurgeon has declared brainstem death. You are in the process of optimizing the patient. Now, being an intensivist and an anesthesiologist, you are constantly in the view of the attenders. So most of the time, you are now left with the attenders who have to grieve. Now they will go through all shocks of denial, anger, frustration, depression. So how do I deal with it? Next. So we go by the protocol. We go by the protocol spikes. It's very easy and it's very, very comfortable while counseling such patients who have just heard a very bad news. So S will stand for you choose a setting which is very calm, very quiet, make them allow them to be seated very comfortably. And first you need to understand what they have understood. The patients might have been counseled or spoken to by the neurosurgeon, the general surgeon, the orthopedician, the cardiologist, a number of doctors. We need to understand what they have understood about the disease. Then you need to ask them, ask them what they would like to know, what their doubts are. Okay, then only you should go on to sharing knowledge. You need to know what they have understood, what they would like to know, and then you need to share the knowledge so that they will understand with absolute clarity. And while doing all of this, always respect their feelings with empathy. If they are angry, be patient. If they want to cry, let them cry. And always, before they leave your room, remember to summarize the entire conversation. This will go on multiple times during the day, throughout the week, because you are the only person who is there 24/7, and you are close to them. So they will definitely want to come back again and again. And during this process, many patients do ask for second opinion, which you should be forthcoming and you should permit. Right. Then comes the multidisciplinary team. Now, maintaining a brain dead patient is not a one-man army. Definitely not. You need a very good team. And as you can see in this picture, each person helps the other person up. Now, that is the success of this program. So, and this team is led by our neurosurgeon and our neurologist who actually identify the patient, and the physician, the nephrologist, the cardiologist, diabetologist, and of course the radiologist. All of them will be coming in multiple times, but it is the anesthesiologist and the intensivist who are actually there, who coordinate around with everybody and make sure a good package is delivered to the patient. And we definitely need a dedicated ICU. Now in Rajiv Gandhi Government General Hospital, we have a 2-bedded unit right adjacent to my emergency department ward. So it's easier. I need not have to make multiple shifts of the patient. And there is the patient's attender are permitted privacy to grieve with the patient if they want to. So what does this ICU have? It has a very good ICU cot. We have a warmer. We have a good ventilator with basic modes of ventilation, a multi-para monitor. Now, this is very important. It should have both invasive and non-invasive parameters and ETCO2 monitoring. And we always go with syringe pumps. Please avoid infusion pumps or on the IV flow. The point of care lab is an absolute necessary amenity, because this point of care lab is right adjacent to my disease donor unit. So most of our surgeons will be coming in. The maintaining physician will want all these tests to be done maybe hourly or second hourly or third hourly. It's imperative because the patient's dynamics keep changing on minute to minute, and you need to be there and correct it as and when it happens. You cannot say 6 hours or 12 hours. It doesn't work that way. So the point of care lab must be dedicated for this organ maintenance ward. And although I have put up an institutional protocol, this is bound to vary from college to college. You need to come up with an institution protocol which is going to suit your respective hospital. We do not, as I said, all through the world over, they do not have uniform institutional standards. But by and large, what do we actually pay attention to? You need to pay attention to the hemodynamics. You need to pay attention to respiratory, the metabolic, and the general. So hemodynamics, please put in you need to put in a central line, an arterial line. Respiratory, always use a very lung-friendly approach in ventilatory strategies. Metabolic, always maintain your serum, potassium, blood glucose, and the hormone replacement and temperature under control. And in general, always make sure you put in a Ryle's tube and antibiotic. Antibiotic is very, very important. Make sure the cultures are sent and antibiotic coverage is given. So I might sound very confident while talking, but many a time I have stumbled and fallen face fall on the ground. So it's not easy when you are working in a team. Many a time we realize how much we do not know. So I'm just sharing a few pitfalls, technical issues, adhering to institution protocols. All of us are used to working alone. When it comes to a team, it has its own hiccups. Adhering to institutional protocol is one such thing. Protocol for negative apnea test or pain responsiveness after brainstem dysfunction, blood alcohol levels. Should we check the blood alcohol levels or not? Invasive BP monitoring. Should we or shouldn't we? Most of the time we want to avoid invasive lines because of the scare of infection. But recently we were just in a dilemma. Should we start this invasive BP monitoring? And comorbidities and apnea testing. When we have a brainstem dysfunction patient who is a CKD patient, or who has decompensated liver disease, or is a coronary artery disease patient with an ejection fraction of 25%, and now this patient has been declared as brainstem death, do we or do we not proceed with apnea testing? Now, these are technical issues which will get a lot of heated arguments across the table, but you have to find some way to arrive at a proper consensus. And of course, logistical issues. It's very difficult to give out memos, and you cannot waste time on people giving out a memo and asking them to come. So we have started a WhatsApp group wherein we have all the specialists under the same roof, including the laboratory doctors. So it's easier to get all reports across the table. And of course, we need more housekeeping staff for the case sheet paperwork, especially at the time of death. And of course, medical legal issues. Now, these are very very confusing at times. It has a lot of discussion, but I hope NGK sir will give us a proper protocol soon. So time of death and form of 10, and now it's come to a proper clarity that the second apnea time is a time of death. And that is the time which will go on that form 10, which will be signed by the neurosurgeons. Then the other medical legal issue is unknown, of course, but the time of death, you need to talk to the patient's attendant and tell them very clear, see, he is dead. We have done the second apnea test. He is declared dead. And that is the time which will be on your brain death certificate. But the patient might die or go in for cardiac arrest maybe 5 days or 6 days later. Now, this 6 days period, you have to be constantly talking to the patient, whether they accept, whether they give consent for donation or not, it doesn't matter. But the patient's attenders have a right to know what this period is, because otherwise they will have a doubt on the heart stop now, you have declared 5 days earlier. So that you need to have a very good rapport with the attenders. Otherwise, there was going to be a lot of miscommunication. Then the other problem area is when you get unknown patients with brainstem dysfunction. Patients who were just brought to the hospital, do we proceed or not? Then non-trauma patients with brainstem dysfunction. Should we proceed or not? Patients from other states with brainstem dysfunction. Patients from Andhra Pradesh, should we? What is the protocol? And then pediatric patients with brainstem dysfunction. That is a discussion in its own. After all of this, when the organ retrieval and the harvesting is done, it is not okay if you just leave the patient just like that. You should always pay final respects. And this is where the patient attenders really hold you in the highest regard. This is one way of giving back and telling them that all our gratitude. So on the left is a picture of this. I think this retrieval was done early last year, and the mother had lost both her husband and her daughter in COVID, and she lost her son too. But in spite of that grief, she was willing to donate her son. And you can see our entire team, our dean, Professor Gopalakrishnan sir, Raghunandan sir, and Vellingri sir, everybody is there paying their final tributes on behalf of the institution. On the right side, this was our youngest donor done early January 2023, an 18-month-old baby from Andhra Pradesh. We are still in touch with the parents, and yeah, it's very hard. It's a very hard and emotional thing to do, but still we need to do it. And this is the latest. 4 days ago, a 63-year-old donor. And 29th, this was a 24-year-old donor. The 28th, the one done on 28th, we handed over the patient to the attenders. That picture was taken at 12:30 a.m. in the morning. And the picture below, that was taken at 2:30 a.m. in the morning. So whatever the time, day, sun or rain, you need to turn up to pay those last respects. So there is no excuse for not doing that. Finally, before I finish, there is no story, no hope, no transplant. But when there is an organ donor, life springs from death, sorrow turns to hope, and a terrible loss becomes a gift. Most of my organ donor patients, they come back to me and say, Madam, decision எடுக்க ரொம்ப கஷ்டப்பட்டோம். But எங்கேயோ ஒரு மூலையில என் சொந்தக்காரர் என்ன பையன், என் ஹஸ்பண்ட் உயிரோட இருக்கிறாரு. அதுக்கு நீங்க எங்களுக்கு வழிகாட்டியிருக்கீங்க. ரொம்ப நன்றின்னு கண்ணீர் மழுக தான் போவாங்களே தவிர, this is an extreme story. It's a tremendous story of hope and life. So I hope more of us will get into it. Thank you so much.
Thank you, Professor Gomati. That was a fantastic talk as usual. You touched upon the basic protocols and the pitfalls and the gray areas. And finally, the philosophical and emotional touch. That is typical of Dr. Gomati. As she rightly put it up, at present, each institution has got their own protocol. There are certain gray areas. But actually, she said that is the right way to go because, you know, the facilities and the logistics in different institutions may be different. I accept your view, but still, what I would like to do is that we will just gather the people who are in charge of maintenance of the brain donor, disease donor across the state of Tamil Nadu. We'll try to get the inputs of everyone. We'll do homework, brainstorm, and better to come up with one common protocol. Let us discuss over it. Let us not be very plastic about it. A lot of adaptability we all need to have, and what is feasible, what is ideal, in between via media we have to walk. I think that will be a that will be very useful for any institution newly getting into this certification of brain death. Initially, there'll be a lot of queries and so on. If you have a protocol as to how to manage and how to go about, they'll get emboldened. That's what I feel. Thank you so much. May I call upon the second speaker?
Good morning. I'm Dr. Tanuj Lamek. I'm an assistant professor in the Institute of Nephrology, Madras Medical College. And today I'll be speaking about how to manage fluids, electrolytes, and acid-base disturbances in a patient who has severe brainstem dysfunction. Now, there's actually precious little in the published literature about this topic, and we are left in doubt about the so there's actually precious little in the published literature about how to manage the minutiae of these complex problems. So what I'm going to be speaking about today is mostly from the gained experience that we have as a team over the last 2 years in managing these patients. Yeah. So first, let's get the ethical issue out of the way. Should a nephrologist who is part of the transplant team even be involved in the management of these patients? So now to clarify, my role in this team is limited to assisting with ICU care. And I would argue that dyselectrolytemias and acid-base disturbances, these are precisely the areas where the input of a nephrologist might be invaluable. So I therefore think that there should be no hesitation on the part of a nephrologist to take up an active role in managing these patients. However, it is also important to know where the boundaries lie. So one should always be conscious of the fact that no member of the transplant team should actually be involved in the certification process. And therefore, I am always conscious to never actually be in the room when an apnea test is done. And I do not participate in the consent process at all. So what are our goals of care? So this is now from the World Brain Death Project, which was a consensus document which was published in 2020. And here they state that there should be no severe metabolic acid base or endocrine derangements that could affect the examination, and these must be corrected. Now, unfortunately, this leaves a lot to the imagination, because what is severe to one person may not be severe to somebody else. So it was initially left to the institutions to decide on their own protocols, and they would then take the call of what is severe and what is not severe. Now, we are grateful to Transplant because they have finally provided us with some clarity about what is acceptable and what is not acceptable. And these are the reference ranges which they had provided. So blood glucose of 60 to 360, sodium of 120 to 160, potassium of 2.5 to 5, pH of 7.3 to 7.45, and a PCO2 of 30 to 45. So where are we at baseline? Most of the patients, by the time that they are certified as having brainstem dysfunction, they already have this trifecta of hypernatremia, hypokalemia, and acidosis. So we'll see one by one how to manage these three conditions. So most of the textbooks, they advise that you do this complex calculation. First, you calculate the free water deficit, and then you calculate the ongoing water loss, and then average that out into a day, and then divide 24, and then you... But then we found that we were very often way off the mark. And this also resulted in a significant positive balance for most of the patients. So now we don't really do these calculations. The fluid which we give is about a few 100 ml higher than the previous hour's urine output. So that's how we manage it here. And the kind of fluid which we give depends on the metabolic derangement. So coming to hypernatremia, there's only 3 ways you can correct this hypernatremia. You either give water by the Ryle's tube, or you give IV 5% dextrose or half normal saline. Now, with regard to water, we were using this initially, but now we've stopped using it, because what we found is when we give an order like 100 ml of water every hour, along with that 100 ml of water, there's lots of air which also goes down the Ryle's tube. So over 24 to 48 hours, the stomach starts to distend and you have a lot of gastric distension. So we try to avoid that. The other thing is gastric absorption is anyway erratic in a patient with brainstem dysfunction. So we prefer the IV route to correct the hypernatremia. With regard to 5D and half normal saline, it should be mentioned that 5D is actually more efficient in correcting the hypernatremia, because the amount of water in 5D is twice the amount of water in half normal saline. So it's actually easier to correct the hypernatremia with 5D. The problem, of course, is your sugars start to go up. And when your sugars go up, you need to give insulin. And when you give insulin, your potassium drops. So therefore, we generally avoid 5D unless the sodium is more than 160. So and if it's in an extreme situation, we give 5D. Most of the other circumstances, we're happy with half normal saline to correct the hypernatremia. So what we do here is whenever we give 5% dextrose, we also add 10 units of insulin into each bottle of fluid. So that takes care of the dextrose which is there in the fluid. So that neutralizes it. In addition, we give a lot of fluids. So we don't want it to be potassium free because the patient is already hypokalemic. So we add 2 ml of potassium to every fluid which we give. Coming to hypokalemia, so we usually give this in half normal saline. We add 2 ampules, so that's 40 milliequivalents. Now, textbook doses of what the upper limit of correction is, about 20 milliequivalents per hour. So if you do the calculation, it's actually 250 ml per hour of this solution. So 2 ampules of KCl and 500 ml of fluid. You can go up to 250 ml per hour. This is, of course, much higher than what most ICUs would be doing, but we found that it is actually quite safe, and we've not had any issues with giving it at this rate. In fact, you need to be aggressive because otherwise these patients lose a lot of potassium in their urine. If you're not aggressive, you're going to have severe hypokalemia and arrhythmias from that. The other thing is hypomagnesemia. A lot of these people also have some alcohol intake. If they've had a road accident, that's quite prevalent in this population. So we generally correct for hypomagnesemia empirically. We give 2 grams of Magsulf in the first pint of fluid as soon as they are certified as having brainstem dysfunction. Coming to acidosis, it's important now that you first correct the respiratory component of this acidosis. For example, in this ABG, the pH is 7.19, the bicarb is 15, and the CO2 is 40. Now, most people would be reaching for the bicarbonate at this point because the pH is low, the bicarb is low, and CO2 is apparently normal. But if you actually calculate what the expected CO2 should be, if you use Winter's formula, the expected CO2 is 30.5. So your level of 40 is actually high. So this is a patient with actually metabolic acidosis with respiratory acidosis. Now, whenever the body has metabolic acidosis, the immediate compensation is an increase in the respiratory rate. Now, unfortunately, that compensation is lost in a patient with brainstem dysfunction. So the respiratory rate is set by the person who is setting the ventilator. So you need to account for that compensation. You need to target a bicarb of not a CO2 of 30 and not of 40 in this situation. And then if you still have acidosis, then you can give your bicarb. Now, while giving bicarb, generally avoid bolus bicarbonate. This is because sodium bicarbonate, 7.5% solution, which is commonly available, this is extremely hypertonic. So if you calculate it, it comes to about 1,700 milliosmoles per liter. This is compared to our blood serum osmolality of only 300 milliosmoles per liter. So it's extremely hypertonic. And when you give bolus bicarbonate, you eventually end up with hyponatremia again. So yeah, it's a self-defeating process by giving bolus sodium bicarbonate. So then how do you give it? You give it as an isotonic solution. So if you have a 7.5% solution of sodium bicarbonate, you mix 80 ml of that fluid with 420 ml of D5. If you have an 8.4% solution of sodium bicarbonate, you add 75 ml of that fluid with 425 ml of D5. This, of course, can be run at 100 or 200 ml per hour until the acidosis is corrected. Now, with regards to fluid balance, this is again always a tug of war because for the lung procurement, they prefer the lungs to be dry and a more conservative strategy with fluid management. The nephrology team, of course, likes to load fluid so that the renal perfusion is maintained. So it's important to strike a balance here. With regard to fluid balance, we have now lots of tools at our disposal. We have the IVC diameter, we have lung ultrasound, Bex's score, echocardiography. Even so, it is still difficult in some situations. It's important to keep track of the cumulative fluid balance. So for example, if somebody is in shock and they're already 3 liters positive balance, it's unlikely that it's hypovolemic. So that also gives you some clue of where you are. Central diabetes insipidus is also very common. These patients often have 700, 800 ml of urine per hour. This forces you to actually replace fluids at 700, 800 ml. So if you do that, you think you're being very aggressive, but actually you're only replacing the losses. You're not actually correcting for anything. So if they had a sodium of 160 to begin with, they would still have a sodium of 160 at the end of your 700 ml per hour of fluids. So what you need to do is actually to switch off that urine output. And for that, you need to give vasopressin. The dose is 0.01 to 0.04 international units per minute. And in practical terms, that's 1 ampule and 50 ml of normal saline started at 1.5 ml per hour and up titrated up to 6 ml per hour. So I'll end with an illustrative case. Now the dates and times have been changed to maintain anonymity. This is a young male who had a road traffic accident certified as brainstem dysfunction on the 28th of March at 9 a.m. His serum sodium was 164 and potassium was 3.4. And these values were taken at 6:15 a.m. that morning. So based on these values, this is how we monitor our patients. We have an hourly chart where we keep the inputs and the outputs. Since his sodium was 164, we started off with 5% dextrose at 500 ml per hour. And we gave that for 2 hours. Next, we got our labs again. We check these every 2 hours. We try to check it every 2 hours. So at 12 o'clock, 2 hours after certification, his sodium was static. It was still 165, but his potassium had dropped to 2.4. So next couple of hours, we made some changes. You'll notice that since we were giving 500 ml per hour of dextrose, the sugars have shot up. This is now 326 and gone up to 381. So to treat that, you need to give insulin. So we started insulin at 5 units per hour. Next, you'll notice the urine output. This is per hour urine output. It was 300 and then it went to 500 and then 1300 ml of urine in that 1 hour. So this again is central. Need to add on vasopressin, started at 1.5 ml per hour. I escalated up to 3. Now you're giving insulin to somebody whose potassium is already 2.4. So you need to again replace the potassium aggressively. So this is half normal saline with 2 ampules of KCl, started at 200, gone up to the maximum dose of 250 ml per hour. Now you'll find that you're giving 500 ml of 5D and 250 ml of half normal saline. So you're giving inputs of 750 ml per hour to manage this patient. And this is still just a few 100 ml higher than the urine output. So we're happy with that input. So what actually happened, we monitor electrolytes every 2 to 3 hours. So you'll see the sodium has nicely trended downwards, 164 all the way up to 152. Now look at the potassium. It was 3.4, dropped to 2.4, after which we gave aggressive correction. It overshot. It went up to 6.6. And then now the reason for this is because we withdraw the D5 and the insulin once the sodium has dropped. So when you withdraw insulin, potassium shifts from intracellular to extracellular and your potassium shoots up. Now you need to wait for the kidney to excrete that potassium. So after that, you can see it trended slowly downwards and came back to our range of 5. So this is just to describe that these patients are very dynamic and you can't have a single prescription. So these are the take-home points, basically. These deceased donors are dynamic and unstable patients. The fluid prescription needs to be tweaked every few hours. You can't just give a prescription and leave. There is no substitute for frequent and vigilant monitoring of labs. You need a rapid turnaround time. We have a turnaround time of only an hour for patients with electrolytes, for our serum electrolyte values. And of course, this is necessarily a team effort. It is not a one-man show. And it is a marathon, not a sprint. It's not just 2 cases and then you sit back and relax. Even after 2 years, we have continued to refine ourselves and continue to change our protocols and learn from each case. So this concludes mine. So thank you for your time and attention.
Thank you, Tanuj. Tanuj is my student turned colleague. He's an asset to our institution. Actually, as Tanuj said, there are a lot of problems. It's not so easy to maintain the dyselectrolytemia and so on. So initially, they devised protocols and then practically they were not feasible and then switched over to the different kind of management. So what the team is doing is that they are just writing it up how the current protocol evolved, and the whole thing has to is to be published in Indian Journal of Transplantation with the case vignettes and so on. That will be very interesting and it will be quite challenging too. So again, I stress upon the strong fundamental physiology that then only you'll become a good clinician and an intensivist. This is a classical example for that. And finally, a brief 10-minute talk by another member of the team, Dr. Jayanti.
Good afternoon. I'll try to keep the topic short. The deceased donor management in an anesthesiologist point of view. That's my topic today. The outline of my topic today will be complications of apnea testing, shifting the patient to OT, and the intraoperative management during organ procurement. So the 3 cardinal signs of brain death are the cessation of functions of brainstem, coma or unresponsiveness, and apnea. The aim of apnea test is to check the integrity of brainstem respiratory center and to prove the absence of respiratory effort even with intense physiological stimulation, that is a rapid rise in PaCO2 to more than 60 mm of Hg. The procedure of apnea testing will be dealt by our Professor Dr. Raghavendra sir. So I will straight away move to the complications of apnea testing. So these are the complications that we face during apnea testing. That is severe hypotension, acidosis, hypercarbia, hypoxia, cardiac dysrhythmias or asystole, and pneumothorax. Severe hypotension. I would say this is the most commonly encountered complication during apnea testing. What we say hypotension is when the BP falls below, the systolic BP falls below 90 mm of Hg. So the apnea testing as such causes there is a resulting vascular dilatation and cardiac depressant effects of carbon dioxide and acidosis that is caused because of the apnea testing. So there is already the central autonomic reflexes in the brain that patients are lost. So this also contributes to the hypotension. What other factors can cause hypotension will be hypothermia, hypoxia, or a negative fluid balance. To avoid hypotension during apnea testing, we should maintain euvolemia or otherwise a positive fluid balance for the previous 6 hours before doing the apnea testing. Otherwise, also you have to take care of this hypoxia portion and also hypothermia portion to avoid hypotension in such patients. When suppose a patient goes in for hypotension during apnea testing, you can even accelerate the inotropic supports and also give the IV fluids. Next comes acidosis. The respiratory acidosis and hypercapnia is a normal expected result of apnea testing. But after the apnea test is being conducted, you have to make certain respiratory ventilatory changes, that is like increasing the respiratory rate to bring back this PCO2 to normalcy or to reduce this acidosis, respiratory acidosis component. This can be checked by doing a blood gas analysis after some time of ventilatory changes. So acidosis as such will also cause a hypotension, and some amount of metabolic acidosis is also possible because of hypotension and accumulation of lactates during the apnea time. This should be tackled with IV fluids. Excessive hypercarbia should be avoided. This can be done by maintaining a baseline PCO2 at the beginning of apnea testing. So what will this hypercarbia do? Again, will be resulting in cardiac dysrhythmias. Hypoxia. Hypoxia leads to hypoxemia and again a risk of cardiac arrhythmia. So this can be better avoided by pre-oxygenating the patient adequately with 100% of oxygen for about 10 minutes before disconnecting the patient from ventilator for conducting an apnea test. Also ensure the apneic ventilation with oxygenation with 6 liter of 100% O2 through a cannula inserted into the ET tube up to the level of carina. But again, there is alternative methods to perform this apnea testing using a T-piece, which can ensure the protection of the lung that will avoid any tracheopulmonary injuries. Also, you can use CPAP with a 10 centimeter of water through a corrugated rubber tube and a valve fitted to it. This will again ensure a good oxygenation and avoid hypoxia and its deleterious effects. Also, they suggest SIMV mode of ventilation can easily help the onlooker to look for the spontaneous respiratory efforts if any is present. There had been cases reported where the larger size of the cannula causing injury to the trachea. Cardiac arrhythmias and asystole. As per some studies, they say 1 out of the 4 apnea tests conducted, patient will go for cardiac arrhythmias or asystole. But this rate is doubled if the patient's borderline BP or borderline saturation is in the lowest level. This can be avoided by maintaining again a euvolemic status and a good pre-oxygenation of the patient. Pneumothorax, last but not the least, this has been reported in a few cases. To our surprise, we also had a case like this, where we had a hypoxic episode after completion of the apnea test, and out of sheer doubt, we took an X-ray and went on with the CT test where we had signs of pneumothorax. So we had to insert an ICD and proceeded with the procurement of the organs. Next part of my topic is shifting the patient to the OT. I would say this is the most weakest link where the patient is disconnected from the ventilator, and during shifting, you should be having a very conscious effort to see all the supports are going in and all the monitors are in place. This is the most tricky part and needs the presence of a senior anesthesiologist or a senior physician or an intensivist to command the team during this time. Make sure the patient receives 100% oxygen before shifting the patient, before disconnecting from ventilator and connecting him to a oxygen cylinder. Or in place, you can use a mobile ventilator unit also. Make sure the oxygen cylinder is full, all the lines are connected, all the central lines are functional, all the peripheral lines are functional, all the supports are going in, the infusion pumps are backed up with battery support. The patient should remain connected to the monitor throughout the period of shifting, and make sure that the hallway, the lift, everything is perfectly ready to tackle the shift of this patient. Because most of the times, if you are not giving clear and loud instructions, this is the time where many blunders can happen. I have witnessed a patient where suddenly there is a drop in BP to 70-30, and we were all wondering what is happening. Suddenly it is about the time we are going to shift the patient. Then we realized our staff personnel has removed all the support that has been going through the central line. thinking that it should be done like that. So it was the mistake on my part because I didn't give the clear instruction to her saying that all the supports, all the IV fluids should be on continuous flow while shifting the patient. The last part of my topic, intraoperative management of the deceased donor. This is essentially a continued intensive care that has been given pre-operatively extended into the operation theater. Preparing the operation theater here, keep all the essential emergency drugs ready, keep the IV fluids pre-warmed, keep all the infusions in which the inotropes, vasopressins, everything should be kept ready, do a routine machine check, receive the patient, connect him to the machine, ensure bilateral air entry is equal, ensure all the inotropic supports are going in, ensure the monitoring is all connected, basic monitoring, ECG, saturation, ETCO2, temperature, and IBP or NIBP, whatever is necessary at that point of time. And again, we go to the hemodynamic management, anesthetic agents. The main anesthetic agents, the three things that we use during this procedure are the muscle relaxants. So anyway, the patient is brain dead, there won't be any brainstem reflexes, but the somatic movements channeled by the spinal cord is intact, and you don't want a panic situation where the patient moves his limbs in the OT table. So there should be a non-depolarizing muscle relaxant given to such patients. And also they claim the sympathetic stimulus and the cardiorespiratory events following nauseous stimulus like the skin incision or handling of the heart can be avoided by giving an opioid. Also, some claim volatile agents can be used to cause a vasodilatation if there is any vasoconstriction on table. This is again a debatable topic. Then hemodynamic management. How do you maintain the saturation? How do you maintain the BP of these patients? The systolic BP should be maintained at more than 100 mm of Hg, or the MAP of 60 to 70 mm Hg should be maintained. So all these brain death patient will be having peripheral vasodilatation. They will have cardiac depressants, myocardial injuries. These are possible. So how do we avoid this? Give the proper IV fluid, which is most common choice is plasmolite A, crystalloids, and also proper inotropic support that has been given preoperatively should be continued intraoperatively also, and titrate accordingly. Don't leave the patient to have extreme stimulus like extreme tachycardia or very high BP. That is not necessary. Titrate the inotropes accordingly. There can be a TEE placed to see the contractility of the heart or the volume status of the heart. That is very useful during procurement of a heart, and also you can balance the fluid and inotropes accordingly. Pulmonary management. Here, two things are very important. One is the fluid management, because brain death as such causes pulmonary edema and also increased permeability of the pulmonary capillaries. This will lead to more accumulation of fluid. In case of a lung procurement, you want a dry lung. I meant to say there should be a judicious use of the IV fluid that is being given. Next is the lung protective strategy of ventilation. That is a high PEEP, that is 6 to 7 mm Hg, and also a low tidal volume of 6 to 7, high PEEP of 7 to 8, and a tidal volume of 6 to 7 ml per kg is enough. And also an FiO2, which is the minimal that can give the maximum saturation, should be maintained. This is a lung protective strategy of ventilation. Also, sometimes they will do a bronchoscopy on the table. So you need to procure the lungs after such procedures to prevent the collapse of the lungs. The hematological management here, some patients may be losing blood somewhere internally or intracranially, wherever. So they may be having an anemia. So as per the rule of 100, you have to maintain at least 10 gram per deciliter of hemoglobin. So this blood transfusions can be done pre-operatively. That is more preferred. And also there can be coagulopathies because of the plasminogen activators or fibrinogens that is released from the ischemic brain tissues. So this should be tackled by doing a TEE or TEG or ROTAM, and proper component of the blood should be replaced according to the TEG or ROTAM. Electrolyte imbalance, as my colleagues have already covered this topic, whatever the electrolyte imbalance that is there, and it is corrected with the fluids, the same fluid should be continued intraoperatively also. During the intraoperative period also, watch the urine output, because this is a long procedure. It can run for 2, 3, 4 hours. So during that period, we should not just ignore this. we should continue the correction. After 1 hour or so, watch the urine output, replace the fluid. Also, if possible, we have to send for hemoglobin, blood gases, and electrolytes every hourly into the surgery. This will help the organs to be kept in the right condition till the end of the surgery. The fluid management, as I said, plasmolite A is the preferred fluid, crystalloid. And also, if not, we can use D5 or half normal saline. All these things will help in maintaining the euvolemic status and also the good functioning of the organs. The restrictive or judicious administration, we have to strike a balance and replace the fluid. The anesthetic care continues until the aortic cross clamp. So finally, I would say care of the donor is essentially the simultaneous care of multiple recipients. Thanks for the opportunity.
Thanks, Dr. Jayanti. It was a very good talk. There were a lot of take-home messages and practical tips studied throughout the structure. Each point which you said is definitely important, particularly for the team who is in charge of the deceased donor. I'll just highlight on one thing which you said, like during the apnea testing, you should avoid the tracheal injury. Instead of putting the tube into this airway, TPs and all that. It's all a practical tip. And I think these things have to be, again, documented, put across for all the centers. We'll have a separate meeting on every component of this. We'll just brainstorm and then put it in paper and then publish that as well. Thank you so much for all the points. And that, shifting the patient, that the weakest link and all that, giving clear instructions, everything is very practical. It was very emphatically expressed. Thank you so much. Next, I would request our guest speaker. He's very well renowned across the globe. He's much wanted in different centers in different continents. He's a multi-visceral organ transplant surgeon, Dr. Swaminathan, to deliver his lecture.
Good afternoon, everyone. I thank Professor Gopalakrishnan sir for giving me this wonderful opportunity. It's indeed a pleasure and honor to be in this Transplant meeting to talk about multi-organ retrieval and overview. So next slide, please. I've got a. Okay. Once all the hard work is done by the intensivist, neurophysician, neurosurgeons, we just come in and take the organs. Our part is quite easy. All the credit goes to the behind the door people who've done all the hard work and pushed the donor into the operating theater. And there's a wonderful team of coordinators who work day and night to get the organ allocation done. Lots of emotion, lots of dramas, and then eventually we end up with a retrieval. The most important thing here is because a retrieval team comes in, they are very new. They wouldn't have met the donor team, but the most important thing here is demonstrate highest regard for the donor family. That should be from the coordinator, the retrieval team which comes, because there'll be a heart and lung team, an abdominal organ team, a liver team, a kidney team, skin harvesting. So everyone should understand that the patient's family, the donor's family is grieving, and we need to give utmost respect to them and try to address their request, be that whatever that is, like in terms of time and in terms of the retrieval ethics. Maintain patient confidentiality. Do not discuss anything about the donor anywhere, even to any of your colleagues. Establish a good working relationship with the donor's healthcare professional, the ones who are managing the intensivist, the transplant coordinator team who is working to get the donor onto the table. And it's imperative for the retrieval surgeon to check the donor consent form, and he has to look through all the brain dead documentation. I'm sure the intensivist and other people will do all the documentation, but it's still the responsibility, it's accountability of the retrieval surgeon individually to check the brain dead documentation. Of course, to check the brain dead donors. Get donor history. get the clinical status. Of course, we are getting all the clinical information through our Transplant video lab, but we keep asking for more information, including the cause of death, duration of cardiac arrest, the duration of hypotension, dyselectrolemia, all the stuffs, hyponatremia, everything matters in the function of the organ, because it's important to get a vital organ, a viable organ, which has a good long-term function, short-term and long-term function. It's important to get a history, go through all the surgical history, previous medical history. Why I'm emphasizing is that because you can see this is one of the donors I opened up. We probably didn't get the history properly. We opened up in the UK. You can see that aorta has a EVAR stent there, endovascular stent. And this is, of course, a DCD, a donation after cardiac death. We got to rapidly slash open the abdomen to cannulate the aorta. Unfortunately, after opening the abdomen, we found that there is an EVAR. It's very hard to cut through that. We got to find some heavy scissors to cut through quickly and cannulate. We lost the liver in that whole process. We could only use the kidneys because of the prolonged warm ischemia time. So that shows to say that we need to get the history properly so we don't lose any organs. Next slide, please. So once you've opened up the retrieval, it's expeditious assessment and recovery of the organs without surgical damage should be the central mission of the donor surgeon. It's retrieval surgery itself is a combination of art and science. The surgeon should be aware of the critical steps. In this presentation, I'm just going to only give an overview of the multi-organ retrieval, so that we prevent, because the organs are precious. After so much of effort, the donor is coming to the OT. We don't want to lose any organs purely because of technical reasons, or we don't want to lose organs or the viability of the organs, or to have a poor outcome purely because of technical errors during retrieval. In fact, the discard rates due to surgical damage is somewhere around 1.4% in a well-established retrieval system like the US and UK. Around 11 to 14% injury occurs during surgical recovery, mostly due to anatomical abnormalities and variations, more common in what is called as a donation after cardiac death or donation after determination of cardiac death. Vascular injury is one of the most common reasons to discard the organs, but nowadays we have a lot of tricks up our sleeve. We can salvage these organs, and we've in fact utilized, now the discard rate has come down significantly. So this is the 2015 opt-in data, which shows that organ injury is somewhere about 22 with about 1.4% discard rate. Similarly, for the liver, organ injury is about 23 and vascular injury is about 14 with a discard rate of close to 2 to 3%. The organ retrieval can essentially be divided into four stages. Warm phase, that's when you prepare the organs before cross-clamping. And then you do a cold phase that the surgeon has to be really fast and quick without causing damage, should take out all the organs before the warm ischemia prolongs, and then backbenching. I would say a good access is vital. We are not doing a minimal access surgery here. So get the whole thing opened, but make it cosmetic. We don't need to really make a cruciate incision. Some people do a cruciate incision, but I think a single midline starting from xiphisternum down to pubis is good enough for exposure. And even if the thoracic organs are not getting retrieved, I would still open the chest because liver retrieval and the kidney retrieval is much more easier with the chest fully open. That's the chest exposure. Then you do some standard steps. I'm not going to go into the detail, but simple. Prepare the at the beginning of the retrieval itself. Try to do some key steps so that in case if the donor becomes unstable and crashes, you should be able to quickly cross clamp, cannulate the aorta, cross clamp, and take out the organs as if you're doing a rapid DCD. So what you do is a right medial visceral rotation to expose the kidneys. Similarly, do the left colonic rotation to expose the left kidney, and then get the aorta slinged at the early part of your retrieval. Keep the aorta ready. Feel the aorta. Make sure that there is no calcification. Find a soft spot where you can cannulate the aorta. Do not dissect too much of the aorta. Going above the IMA, you might injure some of the lower polar renal arteries. Retrieval techniques has been so standardized. It's been practiced for almost a good half a century now. And it's a fellow taught procedure to another fellow, and do very minimally during the warm phase so you don't injure any anatomical variations for liver or kidney. Just go around all the organs, keep it ready, get the aorta isolated. Some people do iliac cannulation, but I think aortic cannulation is much more common because you might end up damaging the ureteric crossing if you do the iliac cannulation. And then prepare the liver. Just do a little bit of very little dissection. Get the bile duct, divide the bile duct, get rid of the bile because bile is toxic, and get the hilar dissection. Don't do too much. Just get the splenic artery, GDA, get the hilum prepared. You can all do it in the cold phase. Then prepare for aortic cannulation. That's very important. You can tell the experience of the retrieval surgeon by just the way he cannulates aorta. Some inexperienced surgeon can get really jittery. There could be a lot of commotion in the operating theater during cannulation. So stay calm. Take a good control of the aorta. The retrieval surgeon and the assistant plays a crucial role as well, exposing the aorta properly. The surgeon must discuss with the entire team. The abdominal team and the thoracic team should liaise together. Then you need to plan a cross clamp time. Because there's always a confusion, someone clamping early. So there is a sequence of motion. The lung surgeon, the heart surgeon, abdominal surgeon, they should all discuss and plan the cannulation properly. Otherwise, you'll end up, losing one of the other organs. And then do not push the cannula too much for the, I'm not going to talk about the thoracic part. Push the cannula not more than 4 centimeters above the aortic bifurcation, because you want the kidneys to be perfused. Even if there are some lower polar vessels arising directly from the aorta, it has to be perfused. So keep it only 4 centimeters above the aortic bifurcation. There could be sometimes difficulties with cannulation, severe atheromas, sometimes aortic aneurysm, where avoid cannulation into the false cavity. Identify the true cavity. Very rarely people have done antegrade cannulation through the thorax. You can request a thoracic team to cannulate from there and antegrade perfusion of the aorta. Remember, there could be some, particularly the elderly donors, there could be some renal renal osteal stenosis, celiac stenosis. Get the IMV, do a dual perfusion, put about 1 liter in the IMV and about 3 to 4 liters in the aorta. Keep in mind in the older donors that the organ perfusion could be poor even after a very good aortic cannulation. Surface cooling. So what we talked about is aortic cannulation, and putting fluid through that is called as a core cooling. That's very important. And then another important step is surface cooling. You need to put a lot of ice. Make sure that there's plenty of ice in the operating theater, sterile ice to cover the entire abdomen. The sequence of taking out the organ is also well established. Usually the thoracic organs go out first. They take anywhere between 15 minutes to 1 hour. I've seen sometimes they're taking 45 minutes to 1 hour to take out the lung and heart. So it is imperative that the abdominal surgeon should cover the abdominal organs until then. I mean, wherever you find space, there'll be always some, shoulder to shoulder space problem there. So wherever possible, the abdominal surgeon should quickly mobilize the liver and kidneys. But if you don't have enough space, let the thoracic organs go out, cover the entire organs with a lot of ice, make sure that the ice will melt, keep pouring in a lot of ice, remove the colon, put it on the surface of the kidney, cover both the kidneys with ice. It is very important that this step is crucial. Otherwise, the organ is going to get warm. As the temperature increases, the viability of the organ drops. There'll be cellular death. And when it reaches a threshold of 15 degrees, you're going to have a rapid cellular death and probably a primary non-function of most of the organs. So this is what I say. It's the need for speed is essential for a transplant surgeon or a retrieval surgeon. As I said, after the core cooling, surface cooling is also very important. Maintain the temperature between 4 degrees. When the core temperature increases or the surface temperature increases, when it reaches close to 15, 17 degrees, which is which can happen within 20 to 30 minutes of, I'm just showing that anastomosis time to give an example. When the warm ischemia increases by about 30 minutes, you're looking at about a temperature of 17 to 20 degrees, and that crosses a metabolic threshold, and that causes rapid cellular death and primary non-function of the liver or primary non-function of the kidneys. So try to cover the kidney with and liver with as much of ice as possible and maintain the temperature. And the surgeon has to be really fast during the cold phase. At the same time, making sure that they don't injure any vessels so that the organs become non-usable. Liver and pancreas, some people retrieve it en bloc, some people separate it in situ. It just depends on the preference of the surgeon. Both of them are equally good. To save time, some people just take it en bloc and separate it in the cold back benching. Using spleen as a handle, we remove the liver and pancreas. And once the liver and pancreas is out, then quickly divide the left renal vein. That's a IVC you're looking at. And the left renal vein is divided. Aorta is divided in the middle. And then and the two kidneys are either again separated in situ or can be taken en bloc and separated in the back bench. So I'm going to skip all those things. Once the kidney is out, liver is out, just make sure that you remove some vessels. It's important because you never know when you're going to need the vessels for reconstruction. Because once you take out the liver, you may sometimes be surprised to find some injury to the vessels due to intimal stretching or direct injury, surgical damage. So you will need all these vessels for reconstruction, or there might be some factors in the recipient. For example, a liver recipient might have a portal vein thrombosis, or the renal recipient might have some iliac vessel issues where you can use these vessels as an extension graft. Remove these vessels and share it between the liver team and the kidney team. It's important to do a proper sterile triple bagging. We've seen in multiple occasions where when the retrieval is done by multiple team, and I'll just give an example. Sometimes a kidney team goes and receives a kidney. The kidney will be lying without much of ice around it. So it's important that each team member has to protect their own organs. They need to make sure that it's triple bagged properly. You put the preservation fluid in the first bag, ice around the second bag and third bag, and then it has to be properly packed in a bag. Next slide, a box. Next slide, please. So this is how you should not be packing an organ. You can see half the basin is up the ice. Please make sure that the organ is fully immersed in the ice and covered all around by ice, because by the time this reaches the transplant center, half the ice would half the organ would be exposed and will not be cold. So cover it fully. Next slide, please. And that's an optimal benching. Next slide. Bench setup. Bench setup is not like a minor procedure where you're going to get rid of some tissues around the kidney or liver. It is again a proper surgery. Make sure that you have a proper bench setup to assess the organ and to prepare the organ for a good implantation. Next slide. Kidneys, just open the gerotas, make sure that the kidney is well perfused. As I mentioned before, if it's an elderly donor, there could be some osteal stenosis. Perfuse the kidney again in the back bench with about 500 ml of preservative fluid of your choice. If there is an osteal stenosis, cut back on the aortic patch and directly perfuse the kidneys. Make sure that the capsule is well kept intact. Assess the vessels and assess the ureter. Next slide, please. Next slide. That's remove all the gerotas and the perinephric fat, because sometimes what happens is we pack the kidney with all the fat around, and then when you go back to your own center and the fat is all frozen, and you won't be able to take it out of the kidney without ripping off the capsule. So as soon as you take out of the retrieval, perfuse it in the back table, remove if there is excessive fat around the kidney, remove the perinephric fat, clear it a little bit. You don't need to do a full back benching, but at least clear a little bit before you pack it in the ice, because the fat can be really hard and get stuck to the gerotas and to the capsule. And we've had incidences where the capsule is completely stripped off the kidney when we try to take out the gerotas, the perinephric fat. Next slide, please. And that's the separation of pancreas and liver in the back table. Next slide, please. I'm not going to go into the detail of those. Once the pancreas and liver is separated. That's a completed backbench liver. Next slide. That's a liver after full backbenching. You can see the hepatic artery, duct, and portal vein ready to be implanted. That's one of our livers we perfused with hypothermic oxygenated machine perfusion. That's particularly useful for marginal organs for liver and kidneys. Next slide, please. And that's a pancreas graft. That's after completion of reconstruction and backbenching. You can see it's attached to the spleen. We remove the spleen after reperfusion with a diurnal C loop. Next slide, please. Again, I put this slide again because after backbenching, please repack the organs. Don't leave it on the table and start doing a respiratectomy or doing your benching. That'll be another 1.5 to 2 hours, the organ sitting, getting warm, and you're going to have a poor quality of organ or a delayed graft function or a primary non-function. So repack the organ, if not 3 bags, at least 2 bags, put a lot of ice around, immerse it fully under the ice, get the bed prepared or take the liver out, and then unpack the organ and take it out. So let the organ cool down so that the core temperature reaches again 4 degrees. Next slide, please. Again, I've shown this slide because it's so important to maintain the core temperature. Now, we do train a lot of people for kidney transplants and liver transplants. During training, the most important thing we do is we tell them to take their own time to do the anastomosis. But what we make sure is we pour a lot of ice salines, ice slush on the kidney, ice slush on the liver, make sure that the organ is kept cold during the red. See, a good experienced transplant surgeon should be able to plumb in a kidney in 25-30 minutes. But then a trainee has to trainee usually takes a little longer, maybe 10-15 minutes longer, but you just have to pour a lot of ice there to keep the organs cold, to maintain the core temperature below 4 degrees. At some point you need to train other people. So we have to give them that opportunity. They can take up to 40-50 minutes. We've seen people taking 50 minutes, 60 minutes. In fact, we do what is called robotic kidney transplants, where we take almost 40-50 minutes to do an anastomosis. What we do there is we create a regional hypothermia. Basically, we put a lot of ice, we cover the kidney with ice, and you take your own time, sweet own time to do the anastomosis. Still the kidney works, the liver works. So the most important thing is maintain the temperature, core temperature. We are trying to keep the metabolic threshold very low and prevent ATP depletion and cell death. Next slide, please. The key points, as I said, proper assessment of the donor, get a good history, talk to the transplant coordinator who's managing the donor, the intensivist who's managing the donor, get some history, get a good assistance. Retrieval is not just some taking out some organ, putting it in the eyes. It is a surgery. It's a technically challenging surgery. It requires a lot of expertise. Adequate exposure, mobilization, avoid unnecessary dissection, anticipate anomalies, a good cannulation, communicate with the whole team, cardiac team, and the abdominal team should liaise and do a good cannulation and perfusion. Keep the organs always covered with ice to maintain core temperature, repack after benching, gentle handling of the vessels with minimal intimal stretching. And most of the retrieval injuries are salvageable. We don't need to discard organs. There's always a way to salvage all the vascular injury, ureteric injury, bile duct injuries, capsular injuries, and there is always a recipient waiting for an organ. So please don't discard organ just because there are some small minor injuries, and communicate with the recipient surgeon. If you're injured, don't think that it's a non-salvageable. Just communicate with the recipient. Say, look, I've damaged the renal artery. I've cut it flush at the hilum. But I've taken some vessels. Can you reconstruct and use it? We've used it multiple times, whether livers and kidneys, which are damaged during retrieval. Damages happen, but we just need to know how to utilize organs. So the discard rate should be actually negligible. Next slide. Thank you.
Thanks very much, Dr. Swaminathan, first of all, for accepting our invitation in spite of your busy schedule. Your lecture has benefited more than 250 participants across the state and some other states as well. Almost everybody's lecture. We are all very keenly watching, and whatever you said is very important. I'll just summarize in one phrase as to what you said. The surgeon has to be cool and the organ has to be cold. That's what you said. That's what you said. And the second point, what he said is that I've already listened to a part of this lecture in a different format, and we keep repeating that in our kind of discussions almost every day, that we minimize the time taken for anastomosis, number one. Even if due to some or other reason, the anastomosis time takes little more time, keep the organ cold. So why? Because that's what he said. The ideal temperature that has to be maintained for the core temperature of the organ has to be 0 to 4 degrees Celsius. Every 1 degree Celsius increase of the surface core temperature of the organ, the outcome is negative. He talked only about delayed graft function and primary non-function. But if the core temperature of the organ crosses 15 degrees Celsius, the outcome, the impact can be really, really disastrous. What do I mean by that? What happens is that if the temperature is not maintained, if it increases 15 degrees Celsius, and if more time is taken for anastomosis, all the toxic metabolites accumulate within the graft and the cellular death happens. And once the anastomosis is completed and clamp is released, all these noxious substances which have accumulated, the toxic substances, they enter into the brain bloodstream, and the result can be two disastrous phenotypes. One, clinical phenotypes. One is a refractory hypotension and death. The second one, a DIC-like picture, profuse bleeding from all vascular beds. This is what happens. So the time is very important, and maintenance of the temperature, the core temperature of the organ is very important. These are the lessons. These are the messages, key messages we have learned from your listening. As a mark of appreciation from Madras Medical College, on behalf of Madras Medical College and Transplant, we'll just honor you with a shawl. May I request Dr. Elias Sundar to honor. And let us move on to the last session. It is going to be delivered by none other than the Director of Neurosurgery, Institute of Neurosurgery, Madras Medical College, Rajiv Gandhi Government General Hospital. He is the key person in certifying brain death, and he has got a vast experience in that. So many brain deaths, and his stewardship has happened by his own self and his team members. I invite Dr. Raghavendra to deliver your lecture.
Madras Medical College and Rajiv Gandhi General Hospital, and Professor N.G.K. Sir, Member Secretary of Transplant, for giving me this opportunity. So to extend, it is a paradox, what Sir said, to be cool and keep it cold. It is a paradox for the certifying team. We need to be calm and keep the donor and the donor family warm. So let me start. So with the blessings of Almighty, I start this topic. And if you look at the mythology behind the image of Lord Ganesh, this is exactly what brainstem death and the concept means. Can any human being do this procedure successfully on another human being? The answer is no. We have transplanted hair, eye, heart, liver, kidney, skin, so many things. But is this procedure possible? It is not possible. That is where the concept of brain death that started, and this is the place where I studied. So before we start, light is the eternal source for life. Without light, there is no life. And sun is the eternal source. But what is a human life? It is like a candle. It burns, it destroys itself. And the duration to which the candle burns may vary based on the length or the thickness of the candle. But as physicians, what is our role? Our role is to keep this flame continues to glow without any trouble. And that is our role as physicians, and that is where we stand here today. So how to keep this burning? we'll see later. Next slide, please. So the flow of the topic today will be, I'll touch briefly upon the concepts of brain death, the definition, the potential where we can see, identify, confirm, and then proceed to certification. So the concept one is, death has always been an all or none phenomenon right from the beginning. Death is not new to us. It is right from the prehistoric and ancient days. How was death identified by all of them in those days? See, there are anecdotal references in caves, paintings, which say, when somebody stopped moving, no limb movement, they were considered as dead. And when somebody stopped, could not open their eyes, they were called as more dead. And when somebody stopped breathing, cessation of respiration, they were called completely dead. This was the anecdotal references of the prehistoric era. And by this, what I mean is, cessation of respiration, permanent absence of respiration was the defining moment by which death was being identified. Until there was a paradigm shift in the 1800s, what happened? Two things. Sir William Harvey identified the cardiac circulation and Linac invented the stethoscope. So we all were fascinated. We understood that cardiac circulation is very important in maintaining the body as a whole. And by way of the stethoscope, we started listening to the heart sounds, and the absence of heart sounds meant absence of cardiac circulation. In other words, death. But it lasted only probably not even a century, less than 100 years only. Today, we are back to respiration. That is what we're going to see. The other concept is the visible death. We all know when we were young, death is imminent in the neighborhood. Somebody is sick, terminally ill, the relatives have gathered. Sometimes the priest comes to anoint the sick, the people are there, and the patient will die at some point of time, being comforted by the religious people and the relatives. But after this was the case till 1940s, and after 1940s, we have seen a tremendous growth in the medicine as a field, and death started happening in the ICUs, invisible death. That is what is meant by away from the patient's relatives. It was the physicians. The death was being witnessed more by the physicians, and these people were comforted by the physicians. So if you look at this graph, it was a serendipity. So 1940s, for the first time, the Danish medical students hand ventilated polio victims when they had respiratory arrest. And in the early 1950s, Sir Egas Moniz, a neurologist, Portuguese neurologist, he did the cerebral angiogram and demonstrated cerebral circulatory arrest, or in other words, absence of cerebral circulation in many of the patients who were in permanent coma. Then mouth-to-mouth resuscitation gained prominent. Mechanical ventilation became a possibility. And in the late 1950s, the first successful kidney transplant was done between identical twins. And in 1959, the neurological criteria, la coma de passe, was described by the French physicians. So when the ICU care improved, the comatose patients, the irreversibly comatose patients or the permanently comatose patients were being maintained for a prolonged duration. All these patients were in deep irreversible coma. They were apneic, their brainstem reflexes, loss of brainstem reflexes. Most of them had diabetes insipidus, cardiovascular system instability. They were poikilothermic and inevitably followed by asystole. This is where the invention of Sir Egas Moniz of the cerebral circulation came into play. Among these most sick patients, everyone who had an absent cerebral circulation did not survive. But among the sick patients who did have a cerebral circulation intact, some of them survived. So that was where they made the differentiation that la coma de passe, irreversible brain injury or absent cerebral circulation is indeed equivalent to death. And these patients, in spite of strict maintenance, the maximum ICU protocols being utilized, will not be able to survive. So how does this happen is we should look at the Monroe-Kelly doctrine back to physiology. The cranial volume is constant, and any injury to the brain, any insult will cause swelling of the brain. And it is not like a forearm or thigh where the swelling happens outside. There is place for the volume to get accommodated, but inside the cranial volume, it is constant. So when the brain starts swelling, the intracranial pressure rises, the cerebral perfusion comes down, and at some point of time when the ICP is refractory and it's a very high level, the circulation stops, and that there is a permanent cessation of brain function. So when do you consider a patient as dead or alive? Is it the circulatory arrest, cardiac circulatory arrest, or absence of respiration? Or do you think consciousness is the most important aspect? As long as I am conscious, I have an identity. My conscious level is my identity. When I lose my conscious level permanently, who am I? Is that the important point? When do you consider somebody as dead or alive? This is what Isaac Asimov said. Life is pleasant, death is peaceful, but it is the transition that is most troublesome, and it is most true as far as brainstem death certification is considered. Today, if you look at dying has become a process. Somebody is getting admitted for a fever, cardiac arrest, code blue initiated, patient wheeled into the ICU, and where does it lead to? He's put on a ventilator, he's put on an ECMO, and we all know he is not going to survive. Everybody goes through the process. Death will happen in such situations only when CPR is withdrawn or ECMO is withdrawn or not provided at all in the first place. That is where we stand here. The advancement, it is an advancement of medical science. I don't deny that. But this has produced a situation like this. And what it led to is, on one side, we have demonstrated to the world that kidney transplant is successful. On the other side, the resources which may be needed for patients who can survive is being occupied by permanently. I don't want to use the word occupied, but in effect, it prolongs the agony of the patient as well as the family members of the patient who is indeed brain dead and is in a prolonged state in the ICU care. So today we have come to a point where death is not a diagnosis anymore, which we had made with a stethoscope, but it is a decision the physician or the intensivist has to take in consultation with the family members. So we were in a situation to we were compelled to redefine what constitutes as death. So this is where, after the La Coma depassed by the French physicians, Henry Beecher, the chair at the Harvard committee, told at whatever level we choose to call death, it is an arbitrary decision. Death of the heart, the hair still continues to grow. Is it death of all organs? Then it is not. Death of the brain, the heart may still beat. So he proposed for the first time, it is best to choose a level where, although the brain is dead, usefulness of other organs is still present. And because of the technological advances, events linked to death in the past are no longer valid. Absent pulse rate, BP not recordable, no respiration, they are no longer valid. Concepts related to death of all organs are also no longer valid. But there is a challenge, a dilemma. Physiological death, yes, it is reversible and sustainable. But there is a mismatch in this resuscitation. Cardiopulmonary resuscitation, heart stops. Many of you would have had the fortune of restarting a heart. The heart will restart, it will function on its own for many years also. But at the same time, when there is a permanent brain damage, the respiration stops permanently. We can put in a tube, maintain the respiration through artificial means, through a ventilator, but are we capable of making the patient breathe again? That is where we stop. We are able to maintain the patient on a ventilator, respiration is taken care of, oxygenation is taken care of, but the heart is functioning on its own. But because of the permanent brain damage, you are not able to make the patient breathe. That is the mismatch. It is reversible, but is it sustainable? Presence or absence of vital signs have been taken away from certifying death. Clinical death is not sufficient today. A patient with a working heart can be pronounced legally dead without clinical death occurring. So as scientific knowledge and medicine advanced, formulating a precise medical definition of death became more and more difficult, but at the same time, you should consider the preserved physiology of brain dead patients. These patients' wound will heal. These patients will fight infections. These patients can attain menarche and menstruate. These patients, a pregnant brain dead patient, can continue to gestate and deliver an alive child. So can we call them as dead? That is the other paradigm or the dilemma or the challenge which we faced. So if you consider the earliest reports were reported by Maimonides in the 12th century, he's a Rabbi physician and a scholar. He said, when will you consider death if a patient is decapitated? Is it the moment when the head is severed off, you will still find that limbs are moving, postures are being maintained. There are so many things. But he made an observation at the time of decapitation, the patient stopped breathing, and he said, brain, by way of controlling respiration, should be considered as the central organ as far as the defining moment of life and death is considered. And it got validated 800 years later by the French physicians. But if you look at brain death has a set of criteria that is reliable and reproducible, crucial in determining our identity. It is the brain, and is as such is not transplantable. So a distinction should be made that brain describes a state that is beyond recovery. We also should look into the dead donor rule, which was proposed by Guy Alexander in 1966. Why do we consider second apnea test as the time of death? Because declaration of the harvesting of organs should not result in death of the donor. That is a rule. In other words, patients cannot donate single organ. Heart cannot be donated, a liver cannot, part of the liver can be donated. So the patient should be declared as dead before multiple organs can be harvested from him. By declaring this, you not only declare him as dead, you are giving permission to put aortic cross clamp. That is the reason they are pronounced dead. So if you look at the cardiac circulatory dying sequence, this is what happens. So if CPR is provided, cessation of circulation, breathing, possibility to resume spontaneously is lost. But if you look at the neurological and circulatory dying sequence, N2 goes directly to N3. So the physiology of death has been revised. Primary or secondary event of brain, primary or secondary event of the respiration, or primary or secondary event of the cardiac. So there is a concept change because CPR and ECMO had defied historical concepts of death determination. So today we all know that the brain is the central organ as far as the defining moment of life and death. So where do we look for these patients? All these patients are found only in the ICU because they are not able to breathe on their own and will need ventilatory support. All of them are on ventilator. Most important aspect is this coma should be because of a neurological cause, not because of anything else. And you should doubt if the patient does not require sedation to be maintained on a ventilator. So identify the GCS is 3/15. And most importantly, we should establish that this GCS 3/15 is because of a neurological cause. We should do a brain image finding, and the image finding should be consistent. That is the first point. It should be consistent with the clinical status of the patient. A small contusion or very minimal changes in the brain will not be consistent with the clinical state. That is the first step. You suspect, you have a doubt, you should look at the brain. Then you look at the fixed dilated pupils, no spontaneous respiration. Sometimes they have diabetes insipidus, and most often they are on vasopressor agents. And the most common etiology in India is trauma, stroke, and aneurysmal rupture. But in abroad, the cerebrovascular accidents play an equal role to trauma. The malignant MCA syndrome or the intracerebral hematoma, hypertensive hematomas, almost equal with trauma in abroad. And so these are the CT findings where you have massive cerebral hemorrhages, which will correlate with the clinical status of the patient. So then you go and check the brainstem reflexes, no response to pain, fixed dilated pupils, Dalsey is absent, calorie test is negative, corneal conjunctival reflex absent, cough and gag reflex is absent. So when you look for the pain response, you should give that painful stimuli only in the supraorbital region or the cranial nerve distribution, and there is no pain response. The pupils should be more than 4 millimeter in diameter and should be fixed without any reaction. So look at the Dalsey movement, the oculocephalic maneuver, it should be absent. And the cold calorie test, which we do, 20 to 50 ml of iced water into the ear canal with a syringe, hold both eyes open and observe for at least 1 minute. If you instill the cold water, it should go towards the side infiltrated, and absent corneal reflex, absent gag reflex, there is no response. Now you come to a set of questions which we call as the yes questions. Etiology known? Yes. Image correlation with the brain image correlation? Yes. toxic causes absent, like sedation, muscle relaxant, alcohol, all these things are absent? Yes, they are absent. Are the metabolic parameters within range? Yes. Is the core body temperature above 35 degrees centigrade? Yes. If you have yes as answer for all these yes questions, then you go to the no questions. Alcohol in the last 6 hours? No. Sedatives, narcotics, relaxants, last 6 hours? No. Brainstem reflexes are? No. Now we have reached a stage where you have suspected, you have identified, image is correlating. All the yes questions have yes as answers and all the no questions have no as answers. Now, this evaluation is done minimum 6 hours after admission, because sometimes we do see when patients are being shifted in an ambulance, they are sedated or paralyzed inadvertently or without any documentation. Wait for 6 hours, then you identify. Then once you identify, the first apnea test is scheduled 6 hours after the identification. But if you suspect anoxemia or hypoxia as the cause for the clinical status of the patient, then you should wait for 24 hours before scheduling an apnea test. If the patient has been diagnosed and certified already as brain dead in another hospital, patient as you have received in the hospital, wait for 6 hours. During this 6 hours, request Transplant to validate whether they have accepted the certifying process in the previous hospital. That brainstem death has been certified. If Transplant says yes, do one more apnea test, the third test, and certify brain death. If Transplant does not agree with the previous hospital findings, start everything as new. So these are the metabolic parameters range as Tanuj, Dr. Jayanti, we have mentioned. Glucose is 60 to 360, pH is 7.3 to 7.45, sodium 120 to 160, potassium is 2.5 to 5, PO2 more than 75, PCO2 is 30 to 45. The vitals, core temperature more than 35, systolic BP is above or equal to 90, or the MAP is consistently above 60 millimeters of mercury. So as mentioned by Professor Lakshmi Narasimhan, there will be a lot of indeterminate movements, and these movements are seen in almost 1/3 of the patients. They may have finger jerks, the undulating toe flexion sign, or the triple flexion response where you have the hip flexion, knee flexion, the dorsiflexion, abdomen reflexes may be present, muscle stretch reflexes, plantar may be upgoing, and you can have a Lazarus sign. And these are indeterminate movements, and you definitely need experience to differentiate them from other movements. So when they express caution, when there is no need for vasopressors, or diabetes insipidus is absent, or when the patient is in shock, or when there is a severe metabolic acidosis. Differ. When the brain imaging is normal and is not correlating with the clinical status of the patient, do not proceed, stop, differ. If the patient has fever, is hypothermic, when there is marked meiosis, myoclonus, or rigidity, abnormal lab values, or when the drug screening is positive, please differ. So what are the red flags? Red flag does not mean we should not proceed. We should proceed with caution. When there is a primary anoxic damage, test after 24 hours, apnea should be scheduled after 12 hours, 24 period should finish, then the first apnea test is scheduled after 12 hours. Same thing for when the patient is hypothermic. When you have neuromuscular disorders or neurotoxins, we do see cobra poisoning is a neurotoxin where the neuromuscular junction is destroyed. But there are reports where the neuromuscular junction has been known to regenerate even after 8 days. So these are situations where you wait for 72 hours and then proceed with the ancillary test instead of going ahead with an apnea test. So when the patient has undergone a decompressive craniectomy within 6 hours or within 6 hours of absent brainstem reflexes, have caution. So these are the potential mimics: GBS, botulism, hypothermia, drug intoxications, sedatives, high spine, cervical spine injury, where the patient is not able to breathe because of a central cause, and the locked-in syndrome. So now, once we have done all these things only, we go to the apnea test. So the prerequisites are, we change the ventilator setting, we pre-oxygenate the patient with 100% FiO2 for 10 to 15 minutes and try to bring the PCO2 just above 40 millimeters of mercury by reducing the minute volume, and put an oxygen catheter 1 centimeter beyond the ET and give oxygen at a flow rate of 5 liters per minute. Alternatively, you can use a vein circuit also. First test is 6 hours after persistent loss of brainstem reflex in trauma, 12 hours after persistent loss of brainstem reflexes in anoxic brain damage. So we do a baseline ABG, then we disconnect the patient from the ventilator, and if we put in the oxygen catheter or the vein circuit, we disconnect it for 8 to 10 minutes. The most important aspect is of the apnea test is we should establish that the patient is not able to breathe in spite of a high PaCO2, which is beyond the threshold level. That is the only idea of doing the apnea test. So we should look for respiratory movements. The Lazarus reflex and other indeterminate movements should not be confused with an respiration. People who have seen the patient will be a huge sigh of breath. The patient will take the perumuchu vidra mari patient edukum. If during the apnea test patient will breathe, that is exactly what a spontaneous respiratory effort means. So after ABG can be taken after 6 minutes, but if the patient is stable, wait for 10 minutes, do another ABG, and then reconnect the patient to the ventilator. So the duration between the two tests, first apnea test and second apnea test, is in adults, it is 6 hours. 31 days of age to 18 years of age is 12 hours, and term newborn baby to 30 days is 24 hours, and there is no consent needed to do an apnea test. When do you want to abort the test? If the systolic BP goes below 90 millimeters of mercury, patient develops significant cardiac arrhythmias. If the saturation falls below 85%, the test has to be aborted. And once the patient is hemodynamically stable, can be repeated after 3 hours. So when do you consider the apnea test as positive? There is no spontaneous respiratory effort. A, the first scenario is the post-apnea PaCO2 is more than or equal to 60 millimeters of mercury, or the post-apnea PaCO2 increases by more than or equal to 20 millimeters from baseline value. For example, if you are starting at 40, if it reaches 60, yes, that is scenario B. In whatever, even if you start at 50, it has reached 65, it has crossed 60, then yes, it meets the criteria A. So when will you call the test is negative? Only when the patient takes a respiration. Only when the patient during the apnea test makes one spontaneous respiratory attempt, it is called negative. And if you have strong clinical grounds, you can repeat it. Once it is negative, you can repeat it after 24 hours. When is it indeterminate? Spontaneous respiration is absent. Rise in PaCO2. For example, you start the test as 43, it has reached 55. In 10 minutes time, the patient has not taken a breath. Then you consider it as indeterminate. And again, if you have strong clinical grounds, indeterminate test can be repeated after 3 hours, whereas a negative test can be repeated only after 24 hours. So once this is done, you can establish that the patient is brain dead and certify accordingly. All criteria for irreversible coma present, yes. All brainstem reflexes absent, yes. Apnea test first and second positive, yes. All yes questions have yes as answer. All the no questions have no as answer. And yes, you can certify, and the time will be the last ABG at the end of the apnea test. That is because of the Guy-Alexander rule. So there are situations where you may not be able to perform an apnea test. So then we need to go to the ancillary testings. When the patient has bilateral facial-maxillary injury, a high cervical spinal cord injury above C4, pulmonary edema, pulmonary aspiration, patient requiring high FiO2 and a high PEEP, chest injury, neuromuscular disorders or neurotoxins, and also when the neurological examination could not be completed. For example, when we neurologically test, we test only the 9 cranial nerves. 2, 3, 4, 5, 6, 7, 8, 9, 10. Actually, the 9 cranial nerves only we test. And if you cannot examine the eye because of a globe injury or a severe periorbital edema, then effectively you are not examining 2, 3, 4, 5, 6, and 8. So that is 6 out of 9 is gone. Then the neurological examination is definitely incomplete. In such situations also, when the neurological examination could not be completed, you should proceed with ancillary testing. But beware, ancillary test is only supplementary. It should not replace the clinical criteria. So you should do the performable test and then proceed with ancillary test. So time of death will be, before doing the ancillary test, we document in the case sheet that the doable or performable neurological tests are all done and it is negative. Then proceed with the ancillary test. Once the ancillary test is done, the patient comes back, returns back to the dedicated unit. You again document that all these brainstem reflexes, everything is absent clinically, because brainstem death is declared clinically with the help of an ancillary test. So that will be the time of death. And if the ancillary test turns out to be negative and you still have strong clinical grounds and suspect brainstem death, you can repeat the test after 24 hours. So cerebral angiogram is the preferred choice as per the Transplant guidelines. And we use the 4-point score where you look at the right and left M4 segment of the middle cerebral arteries and the right and left internal cerebral vein. When there is a score of 4/4, when all these 4 vessels do not take up contrast, there is absence of flow in all these 4 vessels, you get a score of 4/4, then that is positive for absent cerebral circulation. Even a score of 3/4 is negative for brainstem death. So the CT angio has 100% specificity. So in other words, 0 false negativity and 85% sensitivity, because it has a. So you can obtain false negative results when there are situations where the ICP is not rising very high, because bone flap might have been removed, a patient might have undergone a VP shunt for a hydrocephalus procedure where the ICP is not expected to build up, a large fracture or wide open anterior fontanelle in case of a child. So these are situations where you can get false negative results. At the same time, in pediatrics, what I want to stress here is we should express caution because of unresuscitated shock, severe metabolic disorders, locked-in syndrome, GBS. These things can confuse the picture. And at the same time, the data for ancillary testing is very less in pediatrics. So mostly we rely on apnea testing and the clinical criteria as far as pediatrics is concerned. So remember, there is life even after brainstem death, both for the donor. This is a small poem which I have written. I tickle, I pinch, but not a bit do you flinch. Cold water in the ear, eyes sadly do not steer. You are being a sport, not wincing with the tube in the throat. Hypercapnia should trigger, but apnea seems more eager. I'm afraid it appears we must say our prayers and hope that you will give time for another life to fill. So finally, 1,000 kidneys donated by deceased donor program means 1,000 chronic renal failure patients have benefited, but at the same time, 1,000 healthy people do not go under the knife to donate kidney. 1,000 healthy people are spared of a major surgery. And yes, we have always been appreciated by everyone, including the WHO and the national organization. And at the same time, it is also a social responsibility, because during those times, if you Google the word kidney Vakam, it is our own Willy Vakam, where you can get kidneys for 25,000 to 40,000 rupees. And most of these donors were women. The mother, wife, daughter would have donated. This fellow would have happily lived with that money. It is our social responsibility. It is a way of, yes, reducing the women exploitation. So I gratefully acknowledge extremely dedicated neuroconsultants, intensivists, anesthesiologists, transplant team, the administration, Transplant, and the contributions made by all the patients, the relatives who had taken the noble, valiant, gallant decision of donating the organs of the deceased. So finally, it is not a diagnosis we have made with stethoscope. It is a decision today. And the need of the hour is passion towards this program. And we should understand that it is a social responsibility of all our doctors. So to conclude, we have revisited the physiology concepts, which is the central organ of life. The passion should be an uniform decision across the state. We should have a uniform criteria. It is indeed a team effort. It is not an one-man effort. And the very nature is altruism. So how to keep this burning? See, we physicians, we all belong to a noble profession. We have been gifted by the Almighty with the power of taking something from a person who is dead, putting it in some other person who is dying and make him live. We need to be grateful to God for being given that virtue. So to transfer the flame, and yes, one candle can light many. Again, it is a decision we have to take. Thank you so much for the opportunity given. Thank you. Thank you. Thank you. Thank you very much.
Thank you, Professor Raghavendra, for that exhaustive, nice lecture. He touched upon the historical perspective, starting from historical perspectives up to the ancillary tests. It was the complete journey of brain death certification. I hope, like I did, you all enjoyed the talk. And as he said, transplanting one organ into a person with organ failure, it averts living donation. Because now we know the living donation, after living donation, even if the donor is relatively asymptomatic, he or she has to be subjected for scrutiny in the long term. Right now, our department, Institute of Nephrology, we are just following up a cluster of the kidney donors, commercial kidney donors, who chose to donate their kidneys during the tsunami time. And luckily, some voluntary organization has found them out, and they're all brought to us, and we are closely monitoring and scrutinizing. We'll come up with our findings in them. After kidney donation, it is mandatory that a living donor has to be followed up, particularly if they happen to develop diabetes, hypertension, and so on. So a lot of things have to be done. We have to find out whether there is even subtle abnormalities that do take place in the kidney function. There are so much that can be done. So that is a nice point you highlighted. So why I am stressing on that is that I'm not talking against living donation, but considering a living donor transplantation, the disease donor transplantation is definitely superior. It is not, it is obviating the kind of the surgery and the donation of a living organ from a living donor. So, and again, we do have a lot of potential, so many unnatural deaths, particularly road traffic accidents. India has got the infamous title of the leader of road traffic accidents, and that is a sad story. As I have said in my welcome address itself, we need to go all out to minimize these road traffic accidents and the deaths happening over there. Until that ultimate goal is satisfied, whatever disease donor we come across, and we can't afford to waste even a single organ because there is so much of demand. And as every speaker put it across in different ways and forms, they express one thing, that the entire process is not one man or one woman's kind of achievement or something like that. It is a very big team effort. There are so many stakeholders. Each one of us have to understand our responsibility and the commitment with which we have to contribute without violating the norms and rules and regulations in place, and with a great scientific temper underneath. And of course, keeping the donor's family at ease. That is a very important aspect, and it's the most difficult aspect. At this juncture, I thank the team led by Dr. Gomati and the transplant coordinators, the grief counselors. They do extremely good job across the state of Tamil Nadu. See, the kind of mindset the bereaved family will be put in. The news of a brain death suddenly comes like a big shock. And most of these victims are on the prime part of their life. It is very difficult for anyone to get reconciled to what is happening around, It takes some time. The situation doesn't even give time to grieve. So such a aggrieved moment, talking to them about the brain death, the concept of it, and organ donation, it is a lot of sensitivity involved, and it's a very tough job. With folded hands, I pay my gratitude to all those who are involved in that work. You will not know when the process will be over. Sometimes it gets delayed and postponed, and initially there is no, and then subsequently yes. I know the team doesn't even go for food or sleep even for 48, 72 hours and so on. But But considering the sacrifice the family does, family ultimately ends up with, this is a lesser sacrifice. That's what I would say. And I thank all the speakers for their wonderful contribution, scientific contribution to this webinar. And I hope and believe that all the attendees across the state and some outside the state as well, they have gained some knowledge. And this is only a first of such a kind, and such scientific deliberations will continue periodically. And the subsequent deliberations will be thematic. This is a kind of a generalized to start with, and here afterwards we'll identify one particular aspect of the entire process. We'll brainstorm to go into the depths of it and analyze the international literature, understand the changing trends in that, and then we'll come up with the definite solutions. And also the extended donor criteria and how to react when there is a donor with hepatitis B positivity or hepatitis C positivity, age criteria, and all those things. Every component, every aspect of the entire process, it requires a little more of fine tuning and a lot of collaboration, networking, sharing of knowledge. And ultimately, I'm sure that if we all join our hands, we'll really achieve more and more. In Tamil, there is one saying, no? Oor koodi iluttal dhan ther nilai vandu serum. So this is a classical example for that. And I thank all those who are involved in this, particularly my special thanks to my team of Transplant. I have two teams now. One is Institute of Nephrology, MMC. The other team is Transplant. Each one of them is so good. And within a short span of 3 days, they made a lot of arrangements, and they all played a huge role. I don't want to mention any particular name because everybody worked, particularly Bensi, Mr. Janaki Raman, Yuvraj, Sanjay, and everybody. I mean, it's not that I have not mentioned others' names. It doesn't mean that they have not worked. Thank you so much for all those things. Thanks one and all. Thank you. We'll call it a day.